Okay, welcome everybody. This is the start of the Wisconsin Primary CNS Malignancy Syndrome Symposium. And today the context is going to be on vestibular schwannoma. This event is a partnership being sponsored by the University of Wisconsin School of Medicine Public Health, Department of Neurological Surgery, the Medical College of Wisconsin, and the Theta Care Regional Cancer Center. And just as that is a partnership of multiple entities, this topic, vestigial schwannoma, is a partnership. It can only be by a collaboration of medical professionals are we able to understand this disease. It requires understanding of genomics, of pathophysiology, of imaging, of radiation therapy, of surgical therapy, and diagnosis. And I think that's very appropriate that we have so many different specialties today to welcome to this symposium. I think it'll be a very high quality. And as always, this is our co-directors are Dr. Day and Dr. Govey, who I'll now turn the meeting over to for their introductions. Thanks for being with us today.
Thank you, Dr. Dempsey. I'm Mahua Day. I'm one of the neurosurgeons here in the Department of Neurosurgery at UW-Madison. And it is my great pleasure to virtually welcome everyone to our 4th annual symposium. As Dr. Dempsey said, we're going to be focusing on vestibular schwannoma. And its technical surgical nuances, clinical decision-making, selecting the right treatment approach, and innovative clinical trial. Our goal in creating this educational activity is to improve brain tumor care for Wisconsinite by providing updates on cutting-edge development in terms of surgical advances, clinical management, and innovative clinical trial in the field of primary brain tumor while educating future generation of physicians and learning from all the big experts in the field. So, Dr. Bowden.
Thank you so much, Dr. Day. It's such a pleasure to be here again in Madison for our 4th year of Wisconsin's only central nervous system symposium. To collaboratively coordinate the symposium with Dr. Day has always been a pleasure, and the hospitality that the UW Department of Neurosurgery provides to us is second to none. Thank you to Dr. Dempsey, Dr. Day, and our coordinator, Janelle, for assisting us in planning what will be another amazing event. I'm especially honored this year to be representing both the Medical College of Wisconsin and colleagues in my new practice in the Fox River Valley at Theta Care Regional Cancer Center in Appleton, Wisconsin. To my colleagues, both new and old, welcome to our virtual conference. We have a lights out morning conference planned with internationally renowned experts in the field of vestibular schwannoma management. And without further delay, I'd like to introduce our first speaker. Thank you for joining us, Dr. Adunka. Dr. Adunka is a neuro-otologist at The Ohio State University, started his medical training at Medical University of Vienna and completed his fellowship at UNC Chapel Hill. He's currently the director of the Neuro-Otology Division and is funded and widely published in hearing preservation and cochlear implantation. I can also share that he had a hand in training and mentoring my colleague and good friend, Dr. Mike Harris, who is virtually joining us today as well. Dr. Adunka, thank you so much for joining us, and we appreciate you sharing your knowledge with us today on the neuro-otologist perspective in the upfront management of vestibular schwannoma.
Good morning, everyone. I assume you can hear me okay?
You are great. Yep.
Perfect. Yeah, thanks. Good morning. Appreciate you the invitation to speak here. Of course, several connections between Wisconsin with Dr. Roche and then, of course, Dr. Harris. So again, appreciate the opportunity to speak. I'll try to share my screen. I hope this is okay now, correct?
Yep, you're great. Thank you.
Perfect. Okay, so my topic here for the next 30 minutes is on, like you mentioned, the neurotologist perspective on the upfront management of vestibular schwannomas. Dr. Masielak helped me put this presentation together. He's a current neurotology fellow, so certainly this sparked a lot of conversations coming up to this meeting. So here are my disclosures, none of which are really relevant for the current presentation. As we all know, vestibular schwannomas are benign intracranial tumors. The former terms are really acoustic tumor, acoustic schwannoma. I've heard all sorts of names. Vestibuloschwannoma is the correct nomenclature, and really most of us have really gone to use this. They originate either on the superior inferior vestibular nerves. It's interesting when you read the literature on this. Some papers favor the superior nerve. Some other papers favor the inferior vestibular nerve as the nerve of origin. It's probably 50-50, but it makes up about 6% of intracranial neoplasms. Maybe a slightly a greater number just because of the number of MRIs that are pretty much found on every street corner these days. The incidence is about 1.2 to 1.5 per 100,000 per year. Ohio with about 13 million people. So we're probably diagnosing up to 200 new tumors per year for our populations. There are some papers suggesting, again, that with the advent of MRIs being available, again, more widely, that this incidence number is actually higher. And something that is important and almost every patient asks me about is the most common, by far most common, sporadic tumor versus the hereditary bilateral, as is now being renamed into neurofibromatosis type 2 related schwannomatosis. So as we all know as NF2. And again, the upfront management is really important because we usually come in right in the front end of managing these tumors. Because as neurologists, we're uniquely positioned that we really take care of most of the patient's symptoms typically, right? So how do you manage these patients after the initial diagnosis? How do we empower patients for a shared decision-making process? Again, it is a benign disease, and these quality of life considerations are quite substantial. And the upfront decision is usually determined by the patient and tumor factors. So we really usher them through that decision process. We'll talk about this in the next few minutes. Tumor size, hearing, and other functional considerations are really sort of at the forefront here with symptoms. And then patient age and general health take a central role, as we all know. And as I have this funny habit that I take screenshots of many of these acoustic tumors that I see in clinic. And as you can see from this slide, they come in all sorts of different sizes and shapes and cystic components or solid components. And sometimes there are meningiomas, obviously, that are important to distinguish whether or not this is likely not an acoustic tumor or a vestibuloschwannoma. But again, we can see here that the different sizes and shapes clearly warrant a very individualized management approach. Early symptoms typically found in small tumors, but that's not universally true, are unilateral hearing loss, by far the most common hearing symptom, or the most symptom period. Again, that's why we get MRIs on folks with asymmetric hearing loss. And usually transient balance problems that are hardly ever quite persistent, but usually folks presenting with this unspecific disequilibrium and maybe even some vertigo. Late signs, usually from the tumor pushing against the trigeminal nerve, is impaired, facial sensation, and then as a late sign, brainstem compression, cerebellar signs, hydrocephalus type symptoms. The problem is there's a very long latency typically between early and late signs. So in the ENT community, really, we're very careful about not ignoring early signs, because obviously it's a lot better for the patient if we treat these tumors or manage these tumors, start managing these tumors, even if it's just observation, if we know in an early stage here. So do not ignore early signs of these tumors. Diagnosis really very standard kind of practice. Careful H&P. Audio really for this unilateral hearing loss, again, American Academy of Otolaryngology criteria are 30 decibel or more difference between the two ears in 3 adjacent frequencies should trigger an MRI. I can tell you in a tertiary practice, we usually get MRIs more aggressively, so even with less of a mismatch between the two ears. We certainly have seen a lot of acoustic tumors with normal hearing, right? So that alone will not pick up every acoustic tumor as a screening tool. And usually speech and speech discrimination scores really. So the hearing and the understanding parts usually do not match up well. We used to do ABRs for these. It should not be used as a screening tool. However, even stacked ABRs or more advanced ABR techniques have not shown to pick up all of these tumors. So there are quite a few false negatives. So really, unfortunately, we use quite an expensive screening tool as an MRI, right? So, and for MRIs, it's important to get an MRI with and without contrast. For if we decide to monitor a tumor, we can certainly skip the contrast once we understand kind of imaging biology of these tumors. But again, we use MRI with and without as a screening tool. And oftentimes we use more advanced physiologic testing, such as balance function testing, that usually helps delineate the nerve of origin. Specifically use VNG or ENG, which commonly tests the supravestibular nerve, and then VEMP testing to delineate function of the infravestibular nerve, right? And combined, we can usually determine the nerve of origin for smaller acoustic tumors and therefore further stratify the risk for hearing loss during surgery. Again, in some of these smaller tumors. As we mentioned, these tumors come in all four types of shapes and sizes, and what we usually use to classify these tumors is the amount of hearing, and really whether or not the hearing is functional or not used to be this 50-50 rule, meaning that if the patient can understand less than 50% of the words we asked them to repeat, usually the standard hearing tests consists of about 25 words where we ask the patient to repeat these. So the patient understands or can repeat less than 50% of those. Hearing is is most commonly not able to provide the patient with a real benefit. So in other words, they usually are unable to talk on the phone. But again, these kind of subjective findings are somewhat patient specific. And again, non-functional, you basically hear less than 50% of the words, and your thresholds are greater than 50 decibels. So usually halfway down the audiogram for the non-otologist here. And balance symptoms, again, how persistent have they previously been managed medically? Usually these can be managed medically. It's rare that we really have to reach deeper into our bag of tricks and consider surgery for the balance tumors, for the balance symptoms, but certainly has happened in the past, right? And then tumor locations, tumor size, sorry. Small tumors, as illustrated here in the picture up top here, with an intracanalicular tumors, usually they're about a centimeter or less. Once they peek out into the cerebellopontine angle, we're talking about medium-sized tumors, generally speaking, less than 2.5 centimeter in size. And then large tumor, including brainstem compression, here depicted on the lower picture image here with substantial brainstem compressions. Again, those patients will have hydrocephalus type symptoms, as well as facial numbness, etc. So again, one point to reiterate here is that there are little more symptoms between this and this, right? So the long latency of new symptoms that develop between these two stages can sometimes be misleading. So really key to manage these tumors early, to diagnose these tumors, I should say, early on, to avoid these rather large acoustic tumors. And then tumor location, they can arise from really any place in that internal auditory canal and CP angle. So here is a medium-sized tumor, again, less than 2.5 centimeter, without extension into the fundus of the internal canal, the fundus being the most lateral portion of the internal canal. And this fundal fluid has pretty consistently, but not universally, found to be a predictor of successful hearing preservation in some of these, right? Important to note that several of these tumors have intracochlear extension and then extension into the spiral ganglion of the cochlea, so what we call the bony cochlear nerve canal here. in the neurologic literature is an important aspect, right? Is the fundus clear again? Is the inner ear clear? Is the temporal bone eroded? Like on this week on Wednesday, we had a tumor that really eroded, a smaller tumor, probably similar to the one shown up here, that showed quite a substantial erosion into the temporal bone, which can sometimes be not an issue, but sometimes it can make dissection a whole lot more difficult. So these are all kind of things that we look at when we look at MRIs. You know, there's some other details such as the planes, and some folks talk about the anterior extension of the tumor. When you have a bigger tumor, how far does it extend anterior to the ISC? That usually correlates pretty well with a less bundled up facial nerve, so it's usually more of a splayed facial nerve in these kind of scenarios. So how do we decide with a patient really? Really, the upfront management really a decision is really an early decision, mainly between surgery versus observation. Usually in our practice, at least, we reserve radiation for tumors that have demonstrated growth. We cannot determine growth rates without serial MRIs, of course. So radiation, while we offer that, of course, with a gamma knife here, we really reserve that either for recurrent tumors or tumors that had a subtotal resection. But again, for an upfront management, we wouldn't really offer that until we observe for a period of time. And really, you know, when patients first come in, you can sort of get a sense of what their preference is, right? We do feel that patient autonomy is key, and some patients really want this out, and if it's unreasonable, we talk them out of it. Some patients want to observe it, and if that's unreasonable, we try to, you know, have a conversation about that. But really, we need to consider all factors here, and in the next few slides, we'll discuss some of these. When we observe tumors, so MRI surveillance really follows the natural history because we really don't treat the tumor. The natural history is pretty well documented in the literature, especially from Denmark, where national data are available, which demonstrate that most tumors do not grow. That's kind of a statement that a lot of folks make. You know, there's sort of a little bit of an asterisk over a certain period of time, or typically in these studies, 5 to 10 years. Some folks argue that every tumor grows at some point if we wait long enough. The problem is that initial growth does not necessarily mean that that it will predict future growth, and the lack of initial growth doesn't mean they won't grow down the road, right? There's a non-gradual growth pattern that some of these tumors follow, and what's described as well, although less common, is that some of these tumors demonstrate a spontaneous regression. Studies have shown that there's no quality of life detriment from simple MRI surveillance. However, and that's really what I talk to most people about, or everyone about, is that the risk of MRI surveillance really is that folks will lose more hearing. And as we have a little correlation between imaging and hearing function, hearing is definitely at risk. So we can't just look at an MRI and predict how well this patient will hear. So again, in over 10 years of just simple observation, 60% of folks with a sporadic acoustic tumor will progress to non-functional hearing level. Again, even in the absence of tumor growth. So tumor growth by itself does not necessarily predict hearing function over time. In our practice, really, once we have a patient in our office and we discuss this, usually we get the next scan 3 to 6 months after diagnosis. I usually go more to the 6 months range. If a tumor is sort of in the medium range where the patient is elderly and they don't want to do anything, I may go for 4 months. But really, we try to capture really fast metabolizing, so fast growing tumors. Again, that process can be modified, you know, really driven by, again, the initial tumor size and then patient anxiety, of course. And then subsequent recommendations after this are usually based on stability with as growth and the change in hearing, change in symptoms, you know, disequilibrium, balance symptoms, etc. Right? We must assure follow-up, obviously. There's several people that do get lost to follow-up that come back 5 to 10 years later with a very different tumor. So usually we hone it in, you know, we try to make sure patients understand this very well, that a proper follow-up is really required to continue with this path. So microsurgery as an alternative really is operative intervention with the goal of a gross total resection, right? I always tell folks we're a growth total resection center. That's not universally true across practices in the country and especially internationally. The potential benefits are well documented actually in studies, that there's less patient anxiety after therapy. And I always say some patients just want to walk through the door and they just want it out, right? We have to counsel them whether or not that's actually a reasonable way to manage this particular tumor. There's less surveillance after surgery once you've obtained a gross total resection. A gross total resection for especially larger tumors does not mean there's never surveillance, right? And potential preservation of hearing is also another option. The risks, of course, with facial dysfunction, loss of hearing, vestibular dysfunction with folks who do not compensate well, and less commonly a CSF leak, stroke, etc. So other kind of less common intraoperative or postoperative side effects that we certainly want to avoid at all costs. And really, all this must be balanced in a decision making. So usually these conversations are quite lengthy. I usually say that with really large tumors, folks come in with a really large tumors where we would veer them to operative intervention. These initial encounters are actually not as complicated as the ones where patients have relatively good hearing in a small tumor, right? Because those are the difficult conversations. And again, how to get to this surgically, I realize there's some other talks here, so I won't belabor this too much. I do feel like as a center managing acoustic tumors, I do feel like all three approaches should be utilized. So a middle fossa approach, obviously for smaller tumors, with the intent of hearing preservation. Really, that's the main indication for this. Again, we're limited to 1 to 1.5 centimeters on the very high end of tumor size here. The translabyrinthine approach, again, tumors for all sizes really in our practice, that have including of tumors like depicted here with quite substantial brainstem compression, and then a retrosigmoid approach, which does allow for hearing preservation. Again, anatomy often dictates the use of this approach, specifically the position of this posterior canal in relationship to the fundal extension of the tumor, right, as depicted here. So this is sort of a nice retrosig where you can see there's fundal fluid lateral to the tumor, and the posterior canal, although not well visualized here, is probably pretty out of the way. So that's sort of a perfect retrosig. In our practice, I will say, we probably do a third. So we do quite a few, all of these approaches, and really it's a highly individualized decision on how to get to this, right? Another important factor that flows into the patient conversation that we have, the initial conversation, is functional results versus a complete, removal of the tumor. The trend, of course, is to preserve function over obtaining a complete resection, a gross total resection. Sometimes, I shouldn't say often here, we try to really avoid it. So the most common type of resection in our practice is a gross total resection. But if necessary, and we'll usually say that 90% of the tumor takes 10% of the time, and that last 10% of the tumor, and it really takes 90% of our time, and after several hours of microdissection in that area, you really can't get it off that nerve without harming the nerve, right? Then we would leave a small sheath of tumor over that nerve. So again, these types of resections have been discussed in the literature. The gross total resection, as we all know, the subtotal resection, right? That's quite a substantial tumor remnant is left. And usually these tumor remnants are vascularized, so they definitely can show some growth. In my experience, if you leave tumor remnants like more than half a centimeter or centimeter of tumor left, they will grow eventually, right? And then a near total resection, those are interesting, where you really just leave a speck of tumor and usually non-vascularized tumor remnant left on the facial nerve, somewhere between the brainstem and the iris pores, right? A lot of these actually do not show up on MRIs as long as they're small enough, and again, as long as they're non-vascularized, really. There's been, reviewing the literature as this non-vascularity of the tumor remnant being a critical factor here. Facial nerve results between these approaches, also kind of a important discussion to be had with the patient. Mill-Foster approaches, again, not every center offers them. It's a technically challenging approach. It requires some temporal lobe retraction. Certainly, we favor the right side over the left side simply because of the dominant hemisphere problem. But, one of the main issues about tumor dissection is that the facial nerve can be splayed across the tumor surface. The tumor surface that you actually see when opening the door in that area, it might obstruct the view, and oftentimes when you open, you wonder how you're going to get this tumor out, and you just keep whittling away, and that usually does the trick. The translabyrinthine approach, again, the neurotology's workhorse in managing acoustic tumors. One advantage is that the facial nerve is identified in its normal anatomic position within the temporal bone. That was sort of one of the initial, in the 1960s, that was one of the initial advantages. I would argue that with the facial nerve monitoring, the high quality facial nerve monitoring we have these days, it's less of a problem. And we do need to find the facial nerve, again, laterally as well as medially, as I indicated here in the retrosigmoid approach, that the facial nerve is found in the more variable root entry zone at the brainstem. And then hearing preservation, again, a really, really critical topic in the upfront management of these tumors. We provide Mill-Foster again for small intracranial tumors. There's an extended Mill-Foster approach, really a Kawasi drill, as we often call it, mostly used for petrocleval meningiomas, but for acoustic tumors or vestibular schwannomas, really only small intracranial tumors with really favorable hearing, right? Retrosigmoid approach, again, offers this panoramic exposure, extensive drilling of the posterior surface of the temporal bone, making sure the posterior canal is not violated here. One can find the operculum of the endolymphatic sac, and then trace the position of the posterior canal this way. Certain types of MRI findings and markers can be used, as well as physiologic metrics, as I mentioned, VNG and VEM testing. So further advanced vestibular testing can be used to further stratify hearing preservation rates for the patient, right? I do think, I highly think that the nerve of origin is a really important predictor of hearing preservation, meaning that the supravestibular nerve for a Mill-Foster approach has a lot better hearing preservation rates than an infravestibular nerve tumors. And most medium and some small tumors, really, hearing should not really be considered for a selection of the approach when you have when you have medium-sized tumor extending more than 2.5 centimeters. And again, hearing preservation, and I'm sorry I'm harping on this, it's just really a critical piece here, is again theoretically possible with middle and retrosigmoid approaches, but really not possible with a translabyrinthine approach. I think it's worth mentioning here that the advent of our ability to use cochlear implants in conjunction with translabyrinthine approaches has really changed our ability to manage some of these patients up front. And it's something that's definitely evolving, and the ability for us to preserve the cochlear nerve is not necessarily fully fleshed out, but it's something that if a patient benefits from a cochlear implant after having a vestibular schwannoma removed, sometimes these patients can be extremely happy, and you really don't take away a sense such as hearing, but instead we can restore functional levels of hearing. And again, hearing preservation is not just dependent on the preservation of the cochlear nerve, which makes a lot of sense. We also need to leave the labyrinth intact, so labyrinthine integrity and cochlear blood supply. And of course, facial nerve is generally more important, right? And every patient will tell you that before surgery. And hearing is usually, I used to say it's 100% preserved or 100% lost. I've had a few patients where that's not the case, so I shouldn't really say 100% here, but nothing's 100% as we all know. Usually about 70% success with intracranial tumors as long as these are supravestibular nerve tumors. And again, hearing is either all there, we can't improve it. It's an important aspect. You know, some patients are under the impression that we can actually improve their hearing. That's not the case, or hearing is really 100% lost. And in my opinion, really, it's difficult with tumors greater than 2.5 centimeters, right? The success rate of hearing preservation with tumors that size are probably less than 10%. And again, the decision is here really safety versus functional preservation. And oftentimes it's the decision between translab versus middle fossa, right? I won't belabor the translabyrinthine craniotomy because our next speaker will do that. A few words on cystic tumors. They usually indicate an intratumoral hemorrhage. We usually see less upfront hearing levels on these cystic tumors. They're considered less adequate for radiation. Again, we would observe these or provide surgical management. Although with cystic tumors, we probably steer the patient more towards surgical management, although really hard data are really lacking in that aspect. And how to decide, really. I do feel like tumor size and patient age are sort of the main variables here. Tumor size, in generally speaking, really large tumors, we usually steer patients towards surgery. Really small tumors, we usually steer patients to observation. Medium tumors, really all the options are open. Again, those are the discussions that usually take some time. And if you look at the literature, this is a paper from the Mayo Clinic where thresholds of favorable outcomes really worsens right around 17 millimeters, not just tumor size, but really CP angle extension, right? And one should consider surgery right at that kind of size or even before that. Right, so nice piece of data here where they broke down the different symptoms based on tumor size. And again, hearing status, right, is important to remember that hearing status is really only durable if we've taken all the tumor out with surgery and we were lucky enough to preserve hearing. Over time, hearing will drop if watched or radiated, right? Other symptoms are usually best to intervene with surgery. Vertigo, we typically try to manage vertigo non-surgical at first, but if it's persistent and patients have falls, and even if they're a little older, right, we consider surgery. Of course, this is pending extensive vestibular testing here. Facial numbness, facial twitching, etc. Critical part if you have a patient with facial twitching preoperatively, we would certainly be concerned that this may be a facial schwannoma. And tumor will grow over a lifetime, even if they haven't for a decade or longer. Young and healthy, usually we steer patients towards surgery. Even in smaller tumors, having that middle fossa in our tool belt. And old and healthy patients, we really only operate on larger tumors, but usually the focus changes from a gross total resection to brainstem decompression and work again in the confines of our team to provide maybe multimodal management. In majority cases, we push for a shared decision making with an emphasis on quality of life, right? For most of these tumors, unless they're really, really big and a threat to someone's life. We supply information on this on the benign nature of the pathology and all the options that are available. So I think it's really key that the center offers all the available management options. Most patients, and that's actually well documented, you know, most patients read up on this. They go to the Acoustic Neuroma Association. They get information from all sorts of sources. But at the end of the day, most patients will still rely on physician recommendations and tap into the infrastructure, local infrastructure, because your colleagues can mostly assist. And usually having this multidisciplinary center is absolutely critical. And when patients call me or friends call me about patients from all over, you know, the country or world, and family member that has an acoustic tumor, I tell them mostly just go to a big center and make sure they have a team, not just one provider. I think that's absolutely critical. And then a few words on NF2-related schwannomatosis. I know there are other talks. Again, bilateral vestibular schwannomas. There are two types. Again, it's 1 in 40,000 with autosomal dominant inheritance. About 50 to 60% are new mutations, and multiple organ systems involved. So certainly you want to know whether or not this patient has two acoustic tumors, that it's a very, very different kind of clinical scenario, and that will require really neuro-oncologic involvement, et cetera. We'll hear that later today, so I won't really belabor this. But again, I do want to emphasize that a multidisciplinary clinical team is absolutely critical. And I want to say too that we do try to avoid radiation because of a tumor suppressor gene defect. Again, I'll conclude that upfront management is depending on numerous factors such as tumor size, functional state, patient age, and then, patient autonomy, patient preference. Providers must do their homework, define the tumor, really get good MRIs. If a really good MRI is not available, really maybe repeat an MRI, get the data, watch for cranial nerve deficit, and really have a conversation with the patient on what they desire, what fits in their life. Certain situations, however, do take one strategy over the others. Again, very large tumors, debilitating disequilibrium. There's been tried to manage conservatively. Age extremes, really young patient, really old patients, certainly. That would be, certainly cases can be made for surgery versus not, right? And again, important to offer all management options for each center, including also surgical approaches, and then also including stereotactic radiosurgery. And usually, I would say nothing is lost or little is lost with a period observation. However, proper follow-up, absolutely paramount here. Here are my references. I think I shared my slides with Janelle, so happy to have the participants here answer the questions. And I think we have a panel later. So thank you for listening. Again, thanks for having me. Appreciate the opportunity to speak to everyone here, and look forward to the other talks.
Thanks, Dr. Donka. That was a great talk and laying a great foundation for this topic for us to get started. Just a note for all the attendees, if you have questions, please put them in the chat and we'll address all of that as a panel during our panel discussion. And next, we're going to move to our next talk. It is my great pleasure to introduce our next speaker, our very own Dr. Mustafa Bashkaya from UW-Madison. Dr. Bashkaya is Robert J. Dempsey Professor of Neurosurgery at UW-Madison with vast experience and expertise in surgical management of vestibular schwannoma. He's an author of an entire book with surgical video dedicated to vestibular schwannoma surgery, and is recognized internationally for his expertise in this field. And today he will be discussing on how we pick the optimal surgical approach for resecting different types of vestibular schwannoma based on the location that Dr. Donka just touched on. So Dr. Bashkaya.
Thank you, Moha. Thank you for your nice introduction. And I'd like to thank you and Dr. Bowie and all the organizing committee and distinguished speakers for making this day possible. And I heard Dr. Adunka's a very nice talk, nice overview of all the treatment options. So my topic is how we select the best approach for the acoustic neuromas. I'm not going to talk about the selecting the treatment options. I have no conflict of interest, and this is our lovely city, Madison. We welcome everybody. During the spring and summer, beautiful. Winters can be brutal sometimes. So these are the general treatment options: observation, microsurgery, radiation treatment, and hybrid treatment, which is intended subtotal resection and radiation. And the aim of vestibular schwannoma surgery, maximal safe resection, but we should aim for the gross total resection, in my opinion. If you go there for the subtotal resection, you may miss the opportunity performing in some performing gross total or near total resection in some selected cases, and this is possible even in large tumors. And then while you are doing the maximal safe resection or gross total resection, preservation of the normal facial function, and if hearing is serviceable, present, and preserving the hearing, and no mortality, and very minimal postoperative morbidity. And this is the evolution of our surgery now. This is early 1900, how Krause described removing the acoustics with it's called golden finger technique. And it's all about the survival. It wasn't facial function preservation or hearing preservation. Tumors were very large, and surgeons use these techniques. How we select how we select the surgical approach in intracanalicular tumors. I'll start with the small tumors. If tumor is very lateral in the canal, and we know that retrosigmoid approach itself, just drilling the IAC, may sacrifice the hearing. So in those cases, I think middle fossa is perfect approach, is epidural approach, and you just expose the internal acoustic canal. But in a way, it's subtemporal approach, although you are retracting the dura, not the brain, temporal lobe. So it comes with that kind of difficulties. So if there is a good cysternal portion, and it's not very lateral, retrosigmoid approach is the workhorse of the neurosurgery, workhorse of the skull-base surgery. These are the two case examples, similar age group, similar tumor features, and part of the tumor in the canal, part of the tumor in the cistern. But if you look at carefully, here there's a extension of the tumor in the lateral IAC is not that lateral. So there's a fundal cap, CSF signal, and this is a good case for the retrosigmoid. You don't have to drill the entire IAC. As you know, if you drill IAC via retrosigmoid approach, you may sacrifice hearing. So this is middle fossa, although tumor is little, part of the tumor is little more in the cysternal segment. Some surgeons will consider this is not good case for middle fossa, but it was very lateral, and with good neurological collaboration, good neurologist, you can drill this canal and then get the cysternal part of it. And in both cases, you can preserve the hearing, achieve the gross total resection, and that's what we did in these two cases. So middle fossa approach in general, is again another case, is quite lateral in the canal, and it was mentioned that, with the inferior vestibular versus superior vestibular origin, if you can identify or at least get the sense preoperatively which nerve is the true origin of the schwannoma, that's perfect. But most of the time, we cannot get even with the caloric tests or electrodensitography. And middle fossa may create a problem if tumor is originating from the inferior vestibular nerve. But still, there are surgical techniques, microsurgical techniques, you can overcome that. And this is the case. We use the middle fossa approach, question mark or straight type of incision, completely epidural approach. You dissect the dura from posterior to anterior and expose the arcuate eminence, expose the GSPN, and identify the geniculate ganglion with the high facial nerve stimulation. Then this is our neurotology colleague drilling the IAC. Can I drill this? Can I do it? Yes, I can. But collaboration and the sharing the responsibilities and doing the parts you have the most expertise increases the success rate, as mentioned by Dr. Adunka in previous talk. So then we expose the IAC, we open the dura of the posterior fossa a little bit, suction the CSF, that helps the relaxation of the brain. Then you just basically cut the dura, excise the dura, expose the nerves, and you see if this was an inferior vestibular nerve, the you facial nerve is between you and then the tumor. So that creates a difficulty dissecting the tumor of the facial nerve. But this is supravestibular nerve, and it just facial nerve just came to the view a little bit. And by debulking small pieces, that's going to help us to mobilize the tumor more and identify the facial nerve, supravestibular nerve, which is the tumor originating, and then amputating the supravestibular nerve and rolling the tumor away from the facial nerve and the cochlear nerve. And in this case, we were able to preserve the hearing. In my experience, hearing preservation in intracanalicular tumors around 60-65%. Tumor it gets bigger, it becomes more difficult. And this is the good outcome. And then what about the choosing between retrosigmoid and translabyrinthine approach? As you know, if there is a good hearing, we like to preserve, but tumors bigger than 2.5 centimeter, even with the good prognostic audiogram features, hearing preservation chance is less than 5% in my experience. But at least we can try, and we can preserve the cochlear nerve, and that may help to explore the postoperative hearing implant options. So hearing versus no hearing, obviously there's a good hearing like this case. We like to preserve the hearing in young patient, or at least the cochlear nerve. Extent of the internal acoustic canal involvement, you see there's no intracanalicular tumor involvement here, and there is some here. So this is good for the translab. This case is good for the retrosigmoid. And other factors I pay attention, the depth of the brainstem involvement and the width of the, this is in this way, long tumor, but when you drill this mastoid bone, you are looking all this tumor face. And this is perfect case for translab, although tumor is quite large. And this is perfect case for retrosigmoid, because with the translab, we'll have hard time seeing the inferior portion of the tumor. And there are other factors. Position of the sigmoid sinus, high jugular bulb makes the translab is extremely difficult. If it is sigmoid sinus location is very anterior and mastoid bone is very contracted, is not good for translabyrinthine approach. You'll have very limited exposure. And of course, if there is a congenital absence of the contralateral sigmoid transverse sinuses, or for some reason it's occluded in the past, the drilling of the sigmoid transverse sinuses increases the chance of thrombosis, and you are relying on one side of the venous outflow. So these are the factors I pay attention. And now briefly the retrosigmoid approach, how we do it. Main advantage of retrosigmoid approach is you are preserving the hearing, yes, and you have much better control over the lower cranial nerves. But over time, as you gain experience with translab, this is also possible. You just do a little more, be patient about the exposure, and definitely shorter exposure time. But the problem is lateral cerebellum is exposed, and postoperatively, the first few days, retrosigmoid patients, for some reason, they are okay, they are neurologically intact, but they don't feel that well. And the translab patients feel better, they're less nauseated, and they don't feel sick. And the main difficulty, of course, in the retrosigmoid, exposing the lateral IAC. And I haven't had any translab patient who had the postoperative headache, focal post-craniotomy headache. We commonly see after terminal craniotomy, and I see less than 5% of time post-craniotomy headaches in retrosigmoid craniotomy, and some of them can be very rarely very intractable and becomes a major issue in the patient's social life. Description of this, we'd like to do, there are different skin incision. You can do straight, slightly curvilinear. We like to do C-shape incision. I learned this from our ENT colleagues. We always harvest the pericranium and identify, map the transverse sigmoid sinus and their junction, and make the craniotomy and drill the bone over the sigmoid sinus and transverse sigmoid sinus junction, expose the little bit so you can retract the dura, and that increases the exposure of the CP angle and reduces the retraction forces on the cerebellum. Although we don't use self-retaining retractors, I never use it, but still with the suction aspirator, you are retracting the cerebellum. And this is again another case for perfect for retrosigmoid. And there is something we miss in preoperatively. In this case, retrospectively, we identified after identifying intraoperatively. So this is a ICA loop, and that can create a major problem during the surgery. So this is the case to show you that this is retrosigmoid approach. Cerebellum is covered with the surgicells and the talphopedes, so microscopy doesn't affect the cerebellum. Wide exposure, wide arachnoid dissection, releasing the cerebellum, increasing the subarachnoid space and your exposure. And this ICA loop comes and embedded in the dura of the IAC. So if we came middle fossa in this case, there's no way we will be able to do this surgery safely. Luckily, we chose the retrosigmoid because IAC involvement was not too lateral. And now we are mobilizing that ICA loop so we can drill the internal acoustic canal. And its intradural embedment is okay, but sometimes they can go into the bone too. That is super difficult to mobilize. Then mapping the trigeminal, mapping all the nerves, inferior superior vestibular nerve, and I use something I learned from Taka Fukushima, high facial nerve stimulation to map the facial nerve where it might be. In this case, it's easy, small tumor, but in large tumor is very helpful. And I found this ultrasonic aspirator, bone aspirator, is very useful in this location. And then opening the dura of the internal acoustic canal. And this is the superior vestibular nerve where tumor originating, and partially preserving the healthy fibers of the superior vestibular nerve is very helpful to preserve the facial nerve. And then mostly sharp dissection or sharp dissection, semi-sharp dissection. These are sharp metallic knives, and then rolling the tumor away from the facial nerve and the cochlear nerve, and that's the last attachment. So we were able to preserve the hearing in this case, and patient did very well and happy ending. This case, 38-year-old, there's no canal involvement. So, and I worry about going with the translap, this inferior. So I chose the retrosigmoid approach, and we perform all these surgeries together with our neurotology colleagues. Retrosigmoid, translap, or middle fossa, regardless the type of the approach. And this case is went very well, gross total resection and long-term outcome perfect, and he's been doing very well. And another small case, we were able to preserve the hearing in this case. And not always we are able to, but at least 60% of the small tumors I'm able to. And this case I try is large case, more than 2 centimeter in size, young female. We achieved the gross total resection. I preserved the cochlear nerve. Cochlear nerve looked very healthy at the end, but she lost the hearing. And if you lose hearing at surgery, it's immediate. It's not long term. That's different from the radiosurgery. Again, another case I show initial slides, no canal involvement and very deep brainstem involvement. This is a perfect case for retrosigmoid. With translab, you will have hard time to see inferior and deepest part of the tumor with the in the brainstem actually. Now, briefly, translabyrinthine approach. Translabyrinthine approach is, as you know, is popularized by House Clinic, and it's not very familiar approach for neurosurgeon. I learned this in Miami, and then when I came to United States, I had two wonderful neurotologists. Even they taught me more about the translab approach, and we became very familiar with it. Again, same type of incision, C shape, elevating the muscle, more extensive drilling of the mastoid. You drill all the labyrinthine, so you sacrifice hearing if there's any hearing and hearing organs right away, and then you achieve 270-degree internal acoustic canal exposure. And this is the key. If so, you have full control in the IAC, which you don't have in the retrosigmoid. What are the advantages? Early identification, early decompression of the facial nerve, and it's direct route to the CP angle, and is almost purely epidural approach. It is you don't see the cerebellum, you don't need to expose the cerebellum, and that presigmoid dura, posterior fossa dura, protects the cerebellum from you and from your surgical moves. And again, very wide exposure of the IAC, maybe less risk than the retrosigmoid in terms of CSF leak, and in none of my cases I had a postoperative headache, but in general, we neurotologists and neurosurgeons dealing with this, we believe this cause almost no or very minimal postoperative headaches. Disadvantage, if you have a high jugular bulb, it can be problem, and limited exposure of the caudal extension towards the posterior fossa, lower clivus, and anteriorly it can be very difficult sometimes. And of course there are contraindications if mastoid is very contracted, very small and active. Chronic ear infection or acute chronic ear infection is the problem. This is a typical good case for the translab. Our ENT colleague, neurotology colleague, is exposing this, drilling the internal acoustic canal, exposing the jugular bulb. And even if some high jugular bulb cases, I learned this technique from the ENT colleagues. You can gently bipolar coagulate and mobilize it if mobilize the jugular bulb away from your field and increase your exposure. And you identify everything early, and the sharp dissection is key, finding the planes, and then mapping the facial nerve, then coagulating extensively after you mapped it. Rarely you can have a facial nerve schwannoma, and if you miss that, you don't want to coagulate the facial nerve fibers, and they will be dorsal to the tumor and basically facing to you. So sharp dissection if possible, and creating the plane, arachnoid planes, and the rest of the technique is similar to any microneurosurgical technique, and removing it and finding it's in this case, of course, the hearing is sacrificed. We're going to identify the eighth nerve. In some of these large tumors, you cannot really tell eighth nerve. It's blended in the tumor, and this is the feeders coming from the IAC directly. You take those until you are 100% sure they are going to the tumor and they are not en passant arteries, and then you exchange your planes between internal acoustic canal and the brainstem side, and bring two planes together and roll the tumor away from the canal, away from the brainstem. And don't be ambitious for this is for the young colleagues that's trying to remove the tumor in one piece or big pieces. Debulk, make the tumor smaller. And see, initially there was no blood. Now I am next to the facial nerve. I am not coagulating anything, because coagulation can cause also vascular injury to the nervous structures. And gross total resection, this patient is actually 8 years out without any recurrence. Young female, concerned about the facial nerve. We go there with the gross total aim of gross total resection. If you find the tumor, you are losing the facial nerves and you are increasing your stimulator intensity, stop there. You can leave a tiny layer, but the I don't go there to leave the tumor behind. I'll go there to achieve gross total resection. And that's what we did the TransLab. She graduated from the nursing school, grade 2, grade 1, perfect face, no CSF leak or anything like that. Size, initially we worry about the size, tumors like a 5 centimeter, 6 centimeter, and cystic tumors, hydrocephaly. So I suggest these patients, in these patients, put the ventriculostomy, don't put lumbar drain or anything like that. Whichever approach you are taking, first safety, relax the brain, then calm, and this caudal goes all the way to the brainstem. But we were able to achieve gross total resection, but patient needed ventriculoperitoneal shunt placement. This is some phenomenon we see, even though you excluded the tumor and compression of the fourth ventricle and the brainstem. Some patients, due to high protein content, we believe they still have persistent ventriculomegaly and they may require shunt. And retrosigmoid approach, the TransLab is perfect approach for the recurrent residual tumors growing, and you need a virgin avenue, and that's the retrosigmoid approach. 40-year-old female had surgery in California, subtotal resection, tumor is growing. Now patient has intractable trigeminal neuralgia. You can radiate this tumor. I'm okay with it, but I think having the trigeminal neuralgia and intractable is a warning sign to me, and that can be done with the second surgery, and that's we did with the TransLab. And facial nerve wasn't difficulty at all. Previous surgery was retrosigmoid. TransLab gives you a virgin avenue. You don't deal with that scar formed over the cerebellum. You don't even see the cerebellum here. You directly go to the tumor, debulk the tumor, and then I'm just going to fast forward. You see that's all sharp dissection around the facial nerve, and facial nerve wasn't stuck at all. And I don't know why they didn't attempt to remove the tumor, and then the trigeminal nerve was quite stuck, but I got it out. And trigeminal nerve, as you know, very robust nerve and tolerates micro trauma much better than the other nerves. And we achieved the gross total resection, and immediately in recovery room, she was happy. First time in last year, she didn't have any facial pain. And this is another case, retrosigmoid approach. And while they are waiting for the radiation, this is a hybrid surgery. They plan to do radiation after surgery. Tumors start growing. Patient at second opinion, and we removed it. And this patient is from Spain. We don't have the pre-op pictures, but description like 2.5 centimeter, good resection. They left this much tumor and they radiated with the CyberKnife, but tumors start growing in 2 years. So previous surgery, retrosigmoid, this is perfect case for TransLab. And grade 3, immediate, grade 1, facial function, and later. And same subtotal resection, CyberKnife, hybrid surgery, so-called, and tumor is growing. Retrosigmoid gives you the best, TransLab gives you the best result. And post-gamma knife, recurrent tumors, these tumors, they start growing, and this is the perfect case for retrosigmoid actually. But the problem in these cases, there's extensive scarring sometimes. 50% of time, I find the radiation cause scarring. 50% of time, radiation makes actually surgery better because there is no scarring and the radiation took the vascularity of the tumor. Surgery becomes easier and faster. In this case, I was worried about the vascularity because it's obvious radiation didn't take the vascularity and tumor continued to grow. And although there's no IC involvement, I chose to do TransLab. TransLab, you attack the blood supply of the tumor immediately, right at the beginning by drilling the IAC and all the external extradural feeders, you deal with it right away. So you devascularize the tumor with TransLab right away. That's the reason facial grade 2, and good results. And sometimes we do stage surgery for emergency surgeries. I'm going to skip that. And failures, yes, we have failures too. And this is I try my best. Nerve stimulation was getting weaker. I stopped, and his age and other comorbidities play a role too. And we left this much tumor and has been stable because I did the translap and vascularized the tumor. Failure of the approach, this young woman, I thought I can get with the translap. I try. I couldn't see the inferior compartment and I stopped, came back as a second stage with the retrosigmoid and achieved the gross total resection, and she's fine. And another factor, surgeons and everybody else missing nervous intermediates. If small tumors, you can preserve the nervous intermediates. Nervous intermediates as important is very important nerve, very social nerve. If you cannot taste the food you are eating, your social life is screwed. So, and this is the case, smaller case, and most of the time you can identify the nervous intermediates and you can preserve the nervous intermediates. Please try your best to preserve it. And I am skipping this. And so I just conclusion, I already told what is best for the retrosigmoid, what is good for the translap, and in my personal experience, no better approach. As a surgeon, neurosurgeon, we should be versatile with all these three surgical approaches and use the best. And sometimes we shouldn't be insisting about the one approach or one surgery, and logistic dictates sometimes you start the case late, you stop, you can come back next time. And please pay attention and try to preserve the nervous intermediates. This is my surgical results. We have a good results over 2.5 centimeters and almost perfect results in the smaller tumors. So again, thank you very much. Thank you for your time. I'm happy to join you guys later in the panel, and I'm looking forward to hear the rest of the speakers. Thank you.
Thank you so much, Dr. Biscay. That was just a fantastic talk. I was joking with Dr. Day here in the room that for the number of patients that you and I have shared across this I-94 corridor, I still have yet to meet you in person. And yet we're literally probably hallways away and I still haven't met you in person. But hopefully later on today, we'll figure that out.
I will come and say hi to you guys after my first case.
All right, that sounds great. Thanks again. So I'd like to take this opportunity to introduce Dr. Choi, who is a radiation oncologist who joined the University of Pittsburgh Medical Center last year after having previously practiced at Case Western. Her medical training started at the University of Pittsburgh before completing her residency at UCSF. Her research interests revolve around translational and novel therapeutic discoveries in central nervous system malignancies. Her research is supported by grants from the NIH, and she's also an editorial reviewer for multiple peer-reviewed journals in CNS malignancies. Today, she's going to share with us the role of stereotactic radiosurgery in the upfront management of vestibular schwannoma. Dr. Choi, welcome virtually to Wisconsin, and thank you so much for joining us. Oh, you're muted.
Okay, thank you so much for having me. Can you all hear me at all?
We sure can. You're good, and you're sharing your screen.
Okay, great. And all right, so I'm really excited to participate in this virtual meeting, and I want to thank the organizers for inviting me to talk today. So here are my disclosures. So what I'd like to cover today is, here's an outline of my talk: mechanism of radiation, the evolution of stereotactic radiosurgery for the upfront management of vestibular schwannoma, some data on clinical outcomes using our modern practice, and what can patients expect with the treatment, and what to expect with the imaging follow-up in these cases. So just as brief background, this is a benign tumor arising from the myelinating Schwann cells of the vestibular division of the vestibular cochlear nerve. And about 95% of the cases are unilateral and sporadic, so non-hereditary, which is going to be the focus of my talk. We know that it's growing in incidence, about 8% of all intracranial tumors, and patients often present with unilateral hearing loss, dizziness, imbalance, and unilateral tinnitus, prompting neuroimaging with MRI, which has led to the increased incidence of these cases, as illustrated in the image below, comparing the pre-MRI era versus the current era. where there are more detection of these tumors, particularly smaller tumors in older patients, many of them followed. So that lifetime prevalence can be greater than 1 case per 500 persons. The natural history of these tumors is that only about 30% will grow enough over time to require an intervention. And we often think about these tumors in terms of their Coues grading system. This is a classification introduced in 1998, really designed to stratify tumors based sort of indirectly on size, but more in relation to its extrameatal extension and compression of the brainstem. So a grade 1 Coues, grade 1 tumor, as illustrated on the upper left and also on the MRI in figure A, is one that's intracanalicular or within the internal auditory canal. With a grade 2, you have extrameatal extension, but no contact with the brainstem. With a grade 3, you have tumor occupying the cerebropontine cistern with no brainstem displacement. And with a grade 4, you have a large tumor with brainstem and cranial nerve displacement. And so while we think of radiosurgery mainly for the management, upfront management of the grade 1, grade 2 Coues grade tumors, I'll be showing some data where actually it's being used across all grades of these tumors. So the primary treatment options for these are observation, microsurgery, and radiation. And I would say the management approaches for vestibular schwannomas significantly were altered by the evolution of particularly stereotactic radiosurgery, which is the predominant form of radiation that's used in the upfront setting for these tumors. In addition, there's some experiences using external beam radiation, which is conventionally fractionated radiation, a small amount of radiation given every day on a protracted course over weeks. But we have data from the US National Cancer Database from 2004 to 2014 describing what was the upfront management for about over 28,000 patients with vestibular schwannomas. And you can see from this data that about 27% of patients underwent upfront SRS as their primary management, as illustrated by the gold bars. The green bars are showing the small proportion of patients that were managed with external beam radiation, and then the yellow resection and the growing use of observation depicted in blue. Very briefly, how does radiation work? The mechanism of radiation, we know that the most important biologic effect of radiation is from its damage on DNA. And so photons can be generated both by a radioactive source such as cobalt-60, which is what's used in the gamma knife machines, or through a linear accelerator. They can also generate photons. But in both cases, it leads to ionization events where an electron is ejected in the surrounding tissue and the atoms of the surrounding tissue that's being treated. And these electrons can directly damage DNA, or more often the type of damage we see is an indirect one, where it is creating free radicals through interactions with the surrounding water in the tissue, and that leads to DNA damage. So this is a very simplistic view of what happens with radiation, but ultimately, this type of damage can lead to multiple types of DNA damage, the most lethal one being DNA double-strand breaks, and when unrepaired can lead to cell death. For many benign tumors like vestibular schwannomas, this death can take months to years. And the way I would say a way the radiation oncologist views cell death is really a loss of reproductive ability, so unable to further grow, and by definition, we would consider dead, although it may still be metabolically active or visible on scans for years. This figure is just illustrating that in reality, the radiation-induced anti-tumor effect is multifaceted, not just at the level of the DNA, but many factors in the environment, including oxygen tension, which is a very strong radiosensitizer, cell intrinsic factors like the intrinsic radiosensitivity, which is driven by the genomics of the tumor, and other mechanisms which may be particularly important for radiosurgery, including injury of the tumor vasculature, which may choke off access of oxygen and nutrients to the tumor, as well as eliciting a heightened anti-tumor immune response by releasing neoantigens that may be identified by the immune system. And all of these can interplay to cause cancer cell death. And much studies are being done in the laboratory setting to understand this, not just for malignant tumors, but also benign tumors as well. So I want to go into what is radiosurgery. So stereotactic radiosurgery was a concept that was developed by the neurosurgeon Dr. Lars Lexell in 1951. And in simple terms, it's the use of multiple convergent beams to deliver a high dose of radiation to a target while minimizing dose to an adjacent critical structure. So here's a depiction of a gamma knife unit. In reality, you don't see these beams, but they are invisible. But it's really just showing the geometry that how do you get high doses to a tumor, let's say in the center of the brain. You have multiple, and in this case, 192 beams crossing from all different areas of the brain, each causing very minimal damage as it passes through that normal tissue. But when they all converge at a central point or the isocenter, it can deliver high doses of radiation to that point while sparing the normal surrounding tissue. And radiosurgery in modern day practice can be delivered by a number of platforms. I just gave some examples below. The one that I'll be talking more about is the gamma knife platform, and the Elekta Esprit is the newest machine. But there are LINAC-based experiences described as well, using the CyberKnife, as well as arc-based therapy using, like, for instance, the Varian Edge is one example as well. The first ever description of radiosurgery being used specifically for vestibular schwannoma was described in 1971. And this was by Lars Lexell at the Karolinska Institute in Stockholm, Sweden. On the left, you see an image of a patient undergoing gamma knife in an earlier version of one of the units where 192 narrow beams of radiation were used. And on the right-hand side, you see an X-ray with arrows pointing to the location of the vestibular schwannoma that was treated. And on the right, the isodose configuration superimposed on the X-ray view of the tumor. And subsequently, there were a number of other earlier experiences described. In 1987, the University of Pittsburgh started to introduce the gamma knife program to the United States. And so the first series published was from Pittsburgh in this Flickinger et al. Paper. And subsequently, the Mayo Clinic published their gamma knife series. And then there was also LINAC-based radiosurgery series described by the University of Florida and Cleveland Clinic as well. And what you can see on this chart is what they all have in common is you'll note that the marginal doses used in these early experiences were quite high, doses that are more akin to what's used for malignant tumors. And the local control, of course, was excellent. But the cranial nerve preservation rates, as well as the cranial nerve 5 and 7, were lower than what we would like. So that led to some room for improvement. But what really, one of the papers that was listed in that chart, what really led to established SRS as a primary standard of care for the management of vestibular schwannomas was this paper that was published in the New England Journal of Medicine. This is long-term outcomes after radiosurgery for vestibular schwannomas of the early Pittsburgh experience. And this was 162 patients treated between 1987 and 1992. You can see here that the average margin dose was 16 gray. As described in that experience, they were sort of reducing their doses over time. And the mean diameter of these tumors was 2.2 centimeters, but ranged by 0.8 to 3.9 centimeters. And what is seen on the figure on the left is when you're following the patients out years after radiosurgery, you can see that you do see tumor regression over time. And in addition, there are also cases where you see no change and very rarely enlargement that when that happens, typically happens within that 4-year time span. So again, I mentioned how we describe tumor control when we think about radiation outcomes. It's really regression or no change. In other words, no further growth. That's considered good local control in terms of radiation outcomes. Of the 149 surviving patients, they also sent out surveys, of which 115 patients returned the questionnaires, and really to get a sense of the complication and patient satisfaction of undergoing this procedure. And what they found was that in about 31% of those patients, there were complications reported that resolved in about over half of them, but still higher than what we might want in these patients. So thereafter, in the 2000s, there was a lot of experiences reported where they were going lower on these marginal doses, more from the 12 to 13 gray and single fraction range, which is what's used right now in our current modern practice. And with that reduction in dose, you see that the progression-free survival or tumor control rate is still excellent. whereas the CNS cranial 5 and 7 preservation rates significantly improved. So one thing that's not really captured in this table is, I would say it's not just about the doses that were adjusted in this period, but also what the table is not reflecting is just the evolution of technology that has happened, going from X-ray based planning to CT based planning to MR based planning, advancements in the machines and what they can deliver, the accuracy, as well as the treatment times. So a lot was going on in this period in addition to dose adjustments that have led to these improvements. I just want to show some data on long-term results from Pittsburgh on what's used more in our modern practice, which is the dosing predominantly 12 to 13 gray, which was sort of established after 1997. And in this series, it was 871 patients treated between 1987 and 2008, with a median follow-up of 5.2 years. And of note, various models of the gamma knife unit, the U, BAC, 4C, and perfection were all used in the treatment of these patients. And this is a table showing the demographics of the patients undergoing upfront radiosurgery in this experience. And they were able to have 326 patients who had audiological follow-up of more than 1 year with Gardner-Robinson grade 1 or 2 hearing, where they were able to describe hearing outcomes with that cohort of patients in this data. But also of note, you can see down here with the Coos classes, grade 1, 2, 3, and 4 were all included in this data set. So, and pretty evenly distributed as well. And what they found was, in terms of progression-free survival, there was 94% tumor control at 10 years. And in terms of the patients with serviceable hearing, the maintenance of serviceable hearing was 51% at 10 years. When they further stratified by age, what was shown is that age less than 45, you saw better hearing preservation, about 76% at 10 years. Additional outcomes that were described in this modern series was on facial neuropathy as well, with 14 patients, 1.6% having a transient House-Brackman grade 2 or grade 3 facial neuropathy. And that's a very low percentage, but of note, all cases were treated prior to 1997 when these higher marginal doses were delivered. And regarding the patients who were treated less than or equal to 13 gray, no patients had a facial neuropathy with those lower doses. In addition, 51 patients, about 5.8%, had trigeminal neuropathy, and 30 patients presented with a new vestibulopathy in this series. So overall, with this long-term outcomes of the more modern treatment of vestibular schwannomas in the upfront setting, tumor control was still excellent and very favorable in terms of toxicity profile. So I just want to now go through what the experience of going through stereotactic radiosurgery is like for a patient. And I'm going to be focusing on gamma knife specifically, since that's what we use at Pittsburgh. I have images of the two different types of machines that we treat with, the gamma knife icon on the right and the newest machine, the Esprit, on the left. Both have the ability for onboard cone beam CT imaging to allow fractionation for cases as well if needed. But primarily our preference is to use a stereotactic frame for immobilization in order to treat in a single fraction. But for patients who cannot tolerate it, again, there's an option of a thermoplastic mass that can be used. And on the right, I just wanted to share an image of the new Vantage frame, which is supposed to have less MRI artifact and more ease of use with access to the mouth with this new design. So patients will oftentimes show up in the morning. Well, they will show up in the morning. Neurosurgeon will place their frame, and then they'll go get an MRI. These cases are done in a multidisciplinary fashion, so with neurosurgery, radiation oncology, and medical physics all involved in the planning process. And usually we use a high resolution volumetric T1 post-GAD image as well as a T2 to define our targets. And we take particular note at also contouring organs at risk, specifically the cochlea we pay a lot of attention to, especially in patients where we want to preserve hearing, because of data showing that the dose to the medullus, or the central part of the cochlea, can affect, is associated, a lower dose is associated with a higher probability of hearing preservation. So our goal is typically a mean dose of less than 4 or as low as possible, essentially. We typically deliver a single fraction dose of 12 to 13 gray, and we like our plans to have a high selectivity. So we want the treated target volume divided by prescription isodose volume to be as close to 1 as possible. And we also look at the gradient index, which is how steep the dose fall off is, particularly for the half prescription isodose line. So in this case, if you're treating with 12 gray, the 6 gray isodose volume divided by the volume of the prescription isodose. And on the bottom panel, you can see an image of a plan. On the T1 post-GAD image, we always verify on a T2 as well, both our target and the cochlea. And then we've integrated into practice using the cone beam CT to co-register the T1 post-GAD to the cone beam CT to just verify there's been no shifts in terms of the frame or any artifact. And we will use that as a safety check or quality check of our plans. Patients are typically treated the same, within a few hours. So most patients show up very early in the morning and they're done before noon, depending on what order they are and the number of patients being treated. So it's a same day procedure and they're back to their normal activities the next day. As far as clinical follow-up with imaging, we usually utilize a schedule of about 6 months, 1 year, 2 years, 4 years, and then subsequently Q4 years afterwards. And if patients have serviceable hearing, we'll also get an audiogram at the same time points. I just wanted to go through some of the imaging findings that you can get post radiosurgery. One example, first I want to start with the tumor control post SRS. We talked about the fact that whether regression or stability, we would consider that tumor control. And on the left is an example of regression where a patient had radiosurgery and then 8 years later you see significant shrinkage of that tumor. And on the right is an example of stability where we're following a tumor over time and there are some imaging changes within the tumor, but overall the size of the tumor is about the same. There is a phenomenon called pseudoprogression, and it's illustrated in this figure where patients will undergo radiosurgery, and the yellow is the prescription isodose line. And about 6 months post, you may see some changes within the tumor, but almost like an interval growth of that tumor that's extending beyond the original volume of the treated tumor, which can be confused for growth. But as you follow these patients over time, 30 months post, 42 months post, and 54, you can see this gradual decrease in tumor size over time. So it's not uncommon where we might find these early imaging changes, and if symptomatic, may treat with a short course of steroids, which usually does the trick, and then continue to follow over time to make sure that we see resolution of the imaging findings and also improvement of the clinical symptoms. But this was measured painstakingly by measuring the volume of each of the tumors longitudinally over time in 201 consecutive patients treated with Gamma Knife from 2015 to 2019. And all lesions were manually contoured. And what they found in this Pittsburgh report is that there was a transient growth seen in about 34% of patients at 6 months. And then at 18 months, that was about 28%. And interestingly, in the top panel, you have the short-term follow-up, 18 months on the bottom, 54 months after SRS. Most of that growth was seen in the Coues grade 1 and 2 tumors, less so in the grade 3 and 4. And when you looked long-term over time, most of the dramatic changes in tumor volume were seen more so in the grade 3 and grade 4. And growth was considered greater than 20% in volume. That was how it was defined in this series. Here is an example of what treatment failure looks like. Here's a pre-SRS scan where you see this left vestibular schwannoma. At 1 year, you see the volume measured at 1.8, and it appears to be growing. And at 2 years, continued growth, and then also with worsening clinical symptoms, worsening disequilibrium. And what has been described is that the median time until imaging defined progression typically happens between 2 to 3 years post initial SRS in most patients. So it can be challenging to distinguish between late pseudoprogression and tumor progression, but I think using continued growth and clinical deterioration as a criteria within this time frame is helpful. I want to just make note of a concern that comes up with a lot of patients and also providers about the risk of radiation-induced intracranial malignancies when patients are treated with Gamma knife for these benign tumors. And so this paper was published in 2019 in the Lancet Oncology, and it was a multi-center study of patients who had radiosurgery for a number of non-malignant conditions, over 4,900 of them, of which over 1,000 were vestibular schwannomas. And what they found was that the risk of SRS, specifically Gamma knife related intracranial malignancies, was very low. It was reported at 0.045% at 10 years. So this data is reassuring for patients in counseling them when they're thinking about going through radiosurgery for their vestibular schwannomas. So this table just summarizes some of the treatment outcomes, particularly radiographically, that happens post-SRS. We talked about tumor control being greater than 90% in modern series, but pseudoprogression, variable rates of reporting in literature, and it really depends on how it's measured, whether it's two-dimensional measurements, volumetric measurements, but the approximate timeline of these findings are usually 5 to 18 months. The delayed pseudoprogression phenomenon that's been reported, lower rates, but can be seen about 36 to 48 months. So it's important to know that pseudoprogression can happen even years after SRS. And then tumor growth or progression should happen in less than 10% of the time and generally presents with some sort of clinical symptom or deterioration, and usually not considered until 3 years post-SRS unless new symptoms. So just to summarize my talk, upfront SRS for vestibular schwannomas, it's been utilized for greater than 50 years and really has evolved to maintain the high rates of local control, but also improve toxicity rates with different strategies and dosing and technique and technologies. With current modern practice, you still can achieve high rates of functional cranial nerve preservation, and hearing preservation, particularly in younger patients, is still possible. So that's it, and I want to say thank you again for being here for this talk. Thank you.
Thank you, Dr. Choi. That was a great talk on radiosurgery for, especially upfront radiosurgery for vestibular schwannoma. I just want to remind all the participants one more time that if you have questions, which our panel discussion is coming up, so if you want to put those in the chat, we will do that during panel discussion. Next, I have a great pleasure of inviting our next speaker, Dr. Lunsford. He doesn't really need any introduction, but I will still try. He is the authority in the field of radiosurgery versus surgery, or what's the optimal management of vestibular schwannoma, because he is a trained neurosurgeon and a radiation oncologist, so he can compare both sides and give us a balanced overview of his experience. He drove the field. He is probably the author of most of the papers that are defining the standard or management for vestibular schwannoma patients. He's the Lars Lexell Distinguished Professor of Neurosurgery and Professor of Radiation Oncology at Pittsburgh. I have personally learned from Dr. Lunsford and his expertise in his world-renowned Pittsburgh Gamma knife course, which is led by Dr. Lunsford and has trained many generations of neurosurgeons in radiosurgery. So it's truly our honor to have him join us to give his lifelong experience and how we balance surgery versus radiosurgery and all the nuances that goes into it. So Dr. Lunsford.
Thank you very much for this very kind introduction. I hope you can see my slides if I go to full screen. Can you see that?
Yep.
John, thank you.
I'm going to give you a perspective that's been gathered over the course of some 40 years that we've been involved in the field of radiosurgery, and I really enjoyed the talks so far, and especially Dr. Choi's recent summary just a few minutes ago of some of the work that she's involved with now and what we've been doing over the years. So this is a tumor which, as we all know, needs to be decided on an individual basis. What's the best option for each patient? And of course, the consumers, our patients, are often very confused as to what is going to be the best option. I've had personal experience with 3 neurosurgeons in our practice who have had acoustic neuroma. Now, out of the 2,000 plus patients that we've done Gamma Knife for their tumor, of course, this is a relatively small sample, and I'm not going to talk individually about these patients, but simply that they are an educated consumer. And as all of the participants in this panel know, the patient often tries to find as much information as possible. And there are great sources for that information, but there are also a number of sources of disinformation, which periodically show up, leading to confusion in patients as to what is the right option. Over the years, as a neurosurgeon, of course, I've helped in trying to resolve some of this confusion, mainly by long-term data as to outcomes. The procedure itself has basically been pretty much the same since 1997, so more than 25 years. And therefore, what we're concentrated on is understanding the long-term outcomes, the potential benefit, and why do patients need this information in order to make the right selection for what they want to do. So these are my conflicts of interest. I've been involved in outcomes research with our own center and with the Radiosurgery Research Foundation, as well as education related to the Radiosurgery Society. And in our own courses, where we've now trained over 2,800 providers. This includes both radiation oncologists as well as over several hundred neuro-otologists who have taken the course as well. And the work that we will help cite comes from many of those who have collaborated with us over these years and helped to be able to really mine our database of over 18,000 patients who have had Gamma Knife in order to be able to better understand the long-term outcomes for this. And just as microsurgery has shown great improvement over the course of time, you understand acoustic neuromas used to be undergo surgery by picking a big window in the head and using your finger or a dissector to remove the tumor, with often devastating outcomes. And the same with radiosurgery. And while it's been an option, at least hypothetically, for 70 years, in reality, it's been used for almost 4 decades now. So it's always sort of interesting to continue to hear discussions and opinions, often not given with a lot of outcome data as to what is the best option for patients. And our technologies, as Dr. Choi showed, have greatly evolved over the course of time. We've been involved in more than 18,000, now almost 800 patients with this, and a significant number of these patients represent skull-based tumors, meningiomas and schwannomas, and pituitary adenomas and craniopharyngiomas. But what do we neurosurgeons theoretically know that not all patients do? The reality is that these operations, and even though they've had great benefit, have risks. And in this large analysis, looking at the overall outcomes of patients who underwent surgery for their tumor, now almost 5,000 patients in this study, there's a 0.5% mortality rate. 3.1% CSF leak, small percentage of infections, tumor bed hematomas, delayed hydrocephalus requiring a CSF diversion, and many patients who have non-fatal postoperative complications, including things like pulmonary emboli. So there's reason to think that we should have other options for management of this. So let me give you a couple of examples. In 1992, this is an executive from the movie industry who's interested in retention of hearing. He's had episodic hearing loss. Each time with steroids, he has complete recovery of this. He has mild tinnitus and no vestibulopathy. So what are the treatment goals of this professional? It's basically low morbidity, long-term management, as in most of what we see in the world. Hearing loss can be devastating, but a facial neuropathy is also devastating in terms of being able to work in public. So he goes to a variety of centers, and these are the kinds of things that he gets his information. You can understand confusion. Well, just watch it. You can remove it, and if I do it, it will never come back. I can save your hearing if I operate on you. Well, radiosurgery really doesn't work as an alternative. You'll become deaf, and you'll probably have a paralyzed face. When it grows after radiosurgery and then I have to operate on it, it's all going to be stuck, and you'll get a paralyzed face when I try to remove it. And even if it works for a while, eventually you're going to get cancer and you're going to die from that. So you can understand that he would be concerned. But here's 30 years later, he's recently retired. He's got a good golf handicap. And yes, his hearing has gotten worse. His Puritan average of 70 speech discrimination score is not very good. It helps him localize somebody honking on a bus horn for him. But otherwise, he's completely functional. Now, more recently, here's a 47-year-old financial executive now caring for her husband and her children. Her husband recently died, had an episode of tinnitus, gets an audiogram done, which shows some slight reduction in audiogram and speech score. What are this patient's goals? Goes to a prominent West Coast Neurological Center and said, well, you should just watch it. Well, they watched it and it grew. And the surgery is an option. We have a variety of these ways that we can do it. You've heard about them today already. Yeah, maybe you can do radiosurgery, but it has to be done in multiple sessions, not a wheels in, wheels out operation as we do it with Gamma Knife. And there's no long-term data about this anyway. In any case, you're too young to have radiosurgery, whatever that means. So she's 47 years old. That's young. Certainly, I agree. She has a frame-based approach, goes out of the hospital the same day, it's in and out the same day, 12 grade, the margin the next day she flies back to the West Coast. So why do patients get told to watch these their tumor? The average tumor growth rate is a doubling time of 2.5 to 3 years. And of course, in the early generation of books, as this acoustic neuroma monograph from Poole and others, basically these were dealing with very large tumors. But only recently, because of the availability of MRI scan, are we diagnosing these tumors when they were much smaller. But why did these patients get told to observe? In the early days, they were taken to surgery immediately. But then once radiosurgery came around, then the observation strategy began to be offered to more patients over time. And here's the typical example of that strategy over the course of time. Continue to be watched, doubling every 2.3 years by volume, and eventually the patient's going to have to undergo some form of intervention. Well, what are the goals of the procedure? Well, first of all, as you heard from Dr. Choi, the goal is prevention of tumor growth. In many cases, that will lead to growth control or tumor volumetric shrinkage, as we have measured. It is also designed to get rid of all of those open surgical risks that we described at the beginning of this, maintain cranial nerve function, and hopefully, if possible, improve patient symptoms. We do this with a frame-based technique. We do a high-definition MRI scan. In the current generation Gamma Knives, we then augment that with a cone beam CT scan, which allows us to co-register the imaging MRI scan to a skull-based type of CT that allows us to see the cochlea very well and to fine-tune the dose to be highly conformal and highly selective. And the reason it can be done in a single procedure is because the technology allows the rapid fall off of the dose outside of the tumor controlling dose. And so the typical structures nearby, including things like the cochlea, brainstem, gets a very, very low dose. And as you've heard, the radiobiological response of this is mediated by both DNA cell death, but cytokine release. That's why we see sometimes slight enlargement or swelling of the tumor in a certain group of patients. It's not very predictable by the dose or by the volume, actually. And it's designed to lead to delayed cell apoptosis. And part of the aspect of this is to kill the blood supply that makes the tumor grow. And as as you've heard, pseudoprogression, a term I'm not really fond of because I don't think we really know or can tell until time has passed what's true progression versus pseudoprogression. But in any case, what we look about is evidence of temporary enlargement, and it can be in highly measured studies, as Dr. Choi showed from our data, a higher percentage of patients when you're using volumetric measurements rather than linear measurements, which are an unfortunate way that many studies are presented relative to temporary or even long-term changes. So you've heard about and you know about the Coues grading system. This allows us to be able to look at the longitudinal volumetric response over these tumors over the course of time. And as she mentioned, the interesting thing is overall, the greatest volumetric change occurs in the larger tumors, not the smaller tumors, whereas the smaller tumors also getting the same type of low dose 12 gray at the margin, either stabilize, and some patients may have temporary enlargement before they begin to shrink. And that's why we never consider doing anything else until we have evidence of sustained tumor enlargement over the course of time with at least 2 to 3 MRI scans indicating a failure and need for additional treatment. So as we see this blip in tumor volume in a certain percentage of the smallest tumors, which is much less common in the Coues grade 3 and 4 tumors. Remember, these are the tumors that are either touching or actually compressing the brainstem in the fourth ventricle. So in order to fully understand our ability to save hearing, remember the original goal of this is, well, nobody cared about hearing. Everybody's got another ear, right? But reality is hearing loss can be a significant deficit, especially in terms of localizing of sound and location. You can't go to a party or a cocktail party or sit at the dining table and they figure out who's speaking with only one ear. So we began to look at the predictive factors of what could be done to improve the hearing retention score in people who start out with a reasonable level of hearing in the Gardner-Robinson system or the ALA system of greater than 50% speech score and a pure tone average of over 50. And the predictive importance of this are things that often we can't control. That is patient age, and the best results were in patients less than 45, hearing at the time of the procedure itself, and we can assign points to Gardner-Robinson or 1 or 2. Those are the patients with useful hearing, and tumor volume. All of these represent things that we can't affect except by getting the correct dose. And so if we could take each individual patient and put them into this Pittsburgh hearing prediction score at the time that we see the patient age, the Gardner-Robinson hearing grade, and the tumor volume, which we can measure on MRI scan, and we can get check marks related to this to give an idea about what is the actual chance of hearing preservation. So in these patients who have small tumors with normal hearing, and treated in a reasonable period of time, actually the hearing preservation scores at useful levels in these patients can be almost 90% of these patients. Whereas, for example, in grade 5, patients with over, let's say, 60 years of age in larger volume tumors, the retention of hearing over these patients is much less. So we can take an individual measure on these patients and give them a reasonable predictive score in terms of what is the chance that we can save your hearing at a useful level over the course of 10 to 12 years. So in the patients who had a score of 1, the 3-year hearing preservation rates were 100%, in 10 years, 92%. In the patients with big tumors in the older age group with poor hearing, that is Gardner-Robinson grade 2, then we can't do that great a job, but it's still preservation of patients' hearing in some patients. What about the tumor volume? Overall, the long-term tumor control rate is 94%. 3% of the patients in our series have undergone additional management. Only 1% required surgical resection, and less than 2% those with larger tumors to begin with may ended up with a shunt because of ventricular enlargement. Now, one of the things we also looked at is during this, patients who get advised to have waiting, just don't do anything, we'll see what happens with this. Is that have an effect on our ability ultimately to save hearing in these patients? And what we found out, if the patient's interval of observation was less than 2 years, then we had a much better chance of saving the hearing in those patients as compared to those patients who underwent radiosurgery after a period of observation of more than 2 years, which is in fact what happens in the natural history of this. As these tumors grow, then the patient's hearing gets worse over the course of time. So in our experience, observation has a risk because it means that we will have less likelihood of achieving hearing preservation in the patients who underwent this longer observation interval. Now, one of the periods of confusion for all patients is what's the best modality, the best technology, and the best strategy for treatment of this. In our experience, because of the ability to give highly specific and targeted doses with the high precision, we prefer the frame-based approach. Again, a wheels in, wheels out procedure that the patient comes in the morning, goes home the same day, and is back to work, their regular activities, or flies home the next day. But there are many centers that have moved towards using fractionation. In my view, this is largely technology dependent. It's related to the fact that if the device does not allow very sharp fall off of the dose delivery outside of the edge of the tumor, that means that tissue outside of that edge is going to receive a dose that is maybe not tolerable. And the way to reduce that risk of side effects is to divide this into radiation therapy sessions over the course of time. These range from, depending on certain technologies, 3 treatments, 5 treatments, or 30 fractions. Now remember, this is also time consuming to the patient to come in multiple session treatments over the course of time, especially if they're traveling from far away areas, as many of our patients do in terms of this. But there is absolutely no data that shows an improvement in hearing preservation or a reduction in risk in other cranial neuropathies. Now, one of the things that some patients came back and told us about, that they were told by their initial consultations with other doctors, and actually when I first see the patient, I often say, now tell me whom you've seen. What are the doctors you've seen already related to this? Because I can go through 5 or 6 pieces of information which I think needs to be corrected in terms of what the actual data and outcome studies are. One was that patients were being told that tumors that were cystic in nature don't respond to radiosurgery. And we thought, well, that's not what we see in our data. We look at this on a regular basis, and the ones that have cystic changes within them are in fact much more likely to regress, whether it's microcystic or macrocystic changes over the course of time. And when we looked at this, at the percent volume change over the course of time, comparing patients who had no cystic change, that is homogeneous contrast enhancement of their tumor, compared to those with either macro or microcystic changes. In fact, our data supported what we had thought, that is that tumors with cystic changes are in fact much more likely to regress. What about those in which we can define sustained tumor progression over time, often associated with new neurologic symptoms, that is treatment failure? Can we repeat this? And we reported a prior study in the radiation literature, 6 patients. All of these patients achieved tumor control. The typical repeat margin dose that we give to these patients, again with a single frame based technique, is 11 gray at the margin. That is a recent study we're getting ready to submit now, and now with 37 years of experience shows the same results. As part of the Radiosurgery Research Foundation, a larger study looking in multiple centers found 76 patients, 25% of those patients had already failed prior subtotal resection or gross total resection of their tumor, and then required additional treatment. Some patients had microsurgery, again, between the 2 radiosurgical procedures. Not every patient's absolutely straightforward. Some of these patients' tumors behave in a not as great a way. But in this larger period, 80% of the patients who had a second procedure after radiosurgery was repeated had long-term tumor growth control. I want to take a minute to discuss this concept of what is looked at often by imaging studies. In our conferences, I hear this still all the time. Well, this patient had MRI evidence of brainstem compression. Well, look, a tumor doesn't get this big without touching the brainstem. And a Coues grade 4 tumor is associated with some distortion of the fourth ventricle. That doesn't mean that the patient has major symptoms. A patient can have this slow-growing tumor development over the course of time and have virtually no symptoms, no ataxia, no imbalance, and no headache. Those symptoms can be a sign of compression, yes. So a patient with headache or reactive changes such as edema around it and distortion of the fourth ventricle may have symptomatic brainstem compression, but treating on a patient, well, this tumor looks like it's pressing on the brainstem, this patient has to have surgery, is not correct. And in fact, many of these patients will be able to have treatment with regression of their tumor over the course of time. This procedure has extremely low risk. We don't see all of those other complications. There are no pulmonary emboli. There are no tumor bed hemorrhages. There's no CSF leaks. There's no PEs. So a 93-year-old patient can have this tumor. And the reality, even these larger tumors, the long-term tumor growth control of these larger volume tumors with fourth ventricular compression is over 90% of the patients not needing treatment. We thought maybe these bigger tumors we're going to have to reduce the dose, but the reality was that dose reduction to try to theoretically reduce risk, at least using this technology, was not associated with improvement, in fact, worsening tumor control over the course of time. So we don't recommend that. Now, of course, with larger tumor volumes, where not only the eighth nerve, but the seventh nerve is going to receive a higher dose of radiation based on the larger tumor volumes, you can expect the risk of a transient facial neuropathy is going to be higher in this group of patients. And the volume of the tumor that met the high p-value was 10 cc, so you can keep that in mind. And clearly, for smaller tumors where we thought, well, maybe we can give a higher dose and that's what's needed. Basically, the dose has been stabilized now for 25 years, 12 to 12.5 gray in the typical patient. A patient with no hearing, maybe you can give a little bit a dose, but you don't need to. And if you do, it's going to give a higher rate of giving facial neuropathy with doses in the 12.5 and 12 gray. The risk is 1% over the course of time. So what about the patients who do have larger tumors with symptomatic mass effect? In that situation, the outcome of the patient is got to still be the same. The patient wants to be okay. They don't want to be much worse with big cranial nerve deficits. And the one way to achieve a better outcome in these patients is to do subtotal resection, defined from the very beginning. I'm going to take out a part of this tumor. I'm going to try to preserve the facial nerve and bring them back in an adequate condition, which then may allow adjuvant radiosurgery to be performed after they have recovered from the surgery, typically for 3 months or so. We'll wait a little bit longer if after the original surgical procedure the patient develops some degree of facial neuropathy, because we don't want to re-hit that facial nerve that's been partially affected from the surgery until there's been a full recovery from that. So sometimes we see the patient with symptomatic mass effect is a pre-resection tumor, removing mass effect, fourth ventricle is okay. We then do radiosurgery, and then over the course of years, we see delayed tumor shrinkage over the course of time. Now, What about patients who don't have their tumor removed, have radiosurgery, and develop delayed intratumoral hemorrhage, which we have reported in both single center experience at our site as well as in the Radiosurgery Research Foundation. In our experience, this is a relatively rare complication. We've seen 5 out of 1,900 patients. Most of these are larger tumors. We can distinguish this now, and it's very important in the follow-up of these patients. When you're looking for things like edema, you need to do a susceptibility weighted image, which can show you intratumoral blood pigment. And in a certain group of patients, you may need to operate, but vast majority of these patients are not. Dr. Choi previously commented on this because of the data of isolated cases that are out there in the literature about a patient had gamma knife, developed a glioblastoma later on. When this was looked at in this multi-center study reported in Lancet Oncology, the overall risk of this in the vestibular group of patients, as well as other skull-based tumors, was essentially similar to what the history of developing of such a primary tumor is in the brain in a patient who had never had radiosurgery. So and now 37 years into this, in our experience, the overall result of these patients are less than 1% of a facial neuropathy. Yes, in larger tumors compressing the fifth nerve, we actually take steps to try to do dose reduction in the fifth nerve, which can be beautifully seen on MRI scan. But still, the tumors have a 5 to 6% risk. Sensory nerves are in fact more sensitive to ionizing injury radiation than is motor nerves, such as the facial nerve. Hearing preservation, as we've seen, is very much related to the patient age, the hearing at the time of the procedure itself, which typically has gotten worse during the period of observation, and in the tumor volume, because the tumor volumes have grown under observation, then the outcomes are not as good. But over the long run, the tumor control rate is over 10 years at 94%. Now, one of the concerns I have is data from the Medicare database. It's a little bit complex to look at that, but what it's saying is in this 10-year look back in the Medicare database, remember now that means your patients are older, and then on Medicare, what we see is an enormous growth in the usage of radiosurgery. That's the big green line with this over the course of time across the field for radiosurgical indications, not just acoustic neuroma. But one of the things that's happening is the declining participation by the neurosurgeons in the treatment of these patients. And in my view, that's a big problem because, first of all, this is a multidisciplinary approach for this. Patients need to know the risks and benefits of both surgical observation and radiosurgical strategies. And the neurosurgeon really has the greatest experience in the management of these particular patients over the course of time. Yes, it's collaborative effort with many strong professional groups, but I believe that every symphony needs a conductor, and without a conductor, you can't achieve the best outcomes in the music. How does this affect practice training? Well, as radiosurgery grew in our own center, and of course, patients are coming from all over, not just from our region of Western Pennsylvania, it changes how patients are operated on, and this has training effects. How can you teach a person to be an elegant acoustic neuroma surgeon if you're not doing microsurgery? John Robertson, many years ago at Memphis, reported that you have to do 100 acoustic neuromas as a microsurgeon to be able to have sufficient competence to do the next 100 or 100 patients. Well, how do you get to do 100 patients unless the patients are being sent to you for this? And if that's your skill set, of course, we have a lot of training biases across the board, and most of the patients are going to get recommended to have what we as the physician wants them to have. So in summary, why do neurosurgeons, in my experience, have gamma knife as opposed to open surgery? So during the last 20 years, using radiosurgery as the initial management of acoustic neuroma compared to craniotomy, across the world, we can estimate there's been a reduction in deaths. Over 1,000 patients, eliminated 2,400 strokes or hemorrhages, prevented 10,000 CSF leaks, prevented 17,000 patient falsies, and prevented deafness in 36,000 patients in a sample of 100,000 patients who have had gamma knife radiosurgery reported more than 10 years ago. So that's been our experience over the course of time, and that's why we think patients need an unbiased, multidisciplinary approach of the various options that they have. Radiosurgery, at least using the gamma knife, provides a high rate of surgical-free long-term tumor control and cranial nerve preservation. Younger age was a strong predictor of hearing preservation. Smaller tumors with good hearing are ideal. So in our patients, you don't wait, you treat early and treat small when the patients are young to achieve the best outcomes. Thank you for inviting me to participate in the in this panel and in this experience. Thanks for letting us show a little bit of our experience in Pittsburgh over the last almost 4 decades.
Thank you, Dr. Lunsford. That was a great talk, and I would like to invite all our speakers back for the panel discussion. And I would start with the first question. Now, with we've heard from otologists, radiation oncologists, neurosurgeon, and someone who does both. So, is there in today's day and age with the technology we have and the expertise we have, is there any role for observation then for these? Many patients get that recommendation.
I personally think there's definitely a role for observation, at least in the upfront management. So,
and would you elaborate, like, in what particular cases would you recommend observation versus just
well, as I mentioned in my talk, I mean, some of it is patient driven, right? So, and some people just with especially small tumors, right? I mean, I wouldn't recommend to observe a 4-centimeter tumor, but if someone has an intercanalicular tumor and they have perfect hearing and they don't want to have surgery or radiation right now, and again, we do not offer upfront radio surgery. It's something that is a reasonable approach. I mean, it's either that or a middle fossa craniotomy, right? So I realize that practice patterns do differ even within the small group like this, right? So yeah, that's been
Well,
our
I think this need to be data driven, and when people recommend observation, then there has to be a pro and there has to be a con. And in our experience, which may reflect referral bias based on patients who are sent to us who were observed over the course of time, we've presented data which shows that the clinical outcomes in terms of both hearing preservation and other cranial nerve preservation is worse in the patients who are observed for more than 2 years. Of course, there's no database of patients who were observed and live forever happily with never needing anything done over the course of time.
Well, the cohort from Denmark is really kind of the only kind of national database available for that, right? And I think it's pretty clear from that data that observation may actually favor long-term hearing outcomes as opposed to, at least in our center, right? And some of these data, hearing preservation. And I think as neurologists, right, we do have follow these patients long-term and really take care of their symptoms, right? If even if they have been radiated. So I think we're sort of our kind of opinion comes in here. But
Yeah, I think it's very interesting. If you look at that particular series in Denmark, as you may remember, 30 years ago, everybody in Denmark got a craniotomy. And then
right.
after radiosurgery came around, they said now that we should just watch them and not do anything. And so their data suggested, well, maybe that's not a bad idea. And then interestingly, 30 miles away in Norway, the same data was looked at in the Norwegian population, and it found exactly the opposite. It's
Right.
hard to understand that there was huge ethnic difference between the 30 miles across the sound in Norway, where the exact opposite finding was
Right.
found in the Norwegian population, where observation came out as a much worse outcome predictor.
Yeah.
I love the interplay back and forth. This was that was just great. But I think it also highlights me as a radiation oncologist who has a 20-year career at Gamma Knife and now dabbling in CyberKnife. You know, these are the discussions that are worthwhile having, and I think you know everyone had touched on the benefits of a multidisciplinary discussion and having the patients see all providers first, and those that do have a choice, they can make that for themselves after they've heard. You know, what we hope is an unbiased description of all modalities of treatment in addition to observation and the risks and benefits associated with each. So,
And I think, you know, let me chime in here as well, that we use the observation period. Not every patient gets observed, number one, right?
Right.
But if patients do want to get observed, I would completely second what you just said. We have him meet with a team. We have Dr. Palmer here, right, who meets with every patient, and you know, the observation period gives the patient at least this 4 to 6 months period of time where they can make a decision, right? And as we all know, this is not an emergency again, unless we're talking about a really large tumor like a COAST 3 or 4. I would say that, you know, oftentimes patients want that observational period in my mind. Sometimes we get a call back and say, hey, after they met with us, they want to proceed with one or the other. But again, in my opinion, it provides the patient again with that period of reflection that allows them to make a kind of more individualized decision.
I agree. We have a couple questions in our chat, actually. One from Lexi Miles. Lexi, hello. It's good to see you on here. We'll hear from you this afternoon, but this was specifically a question for Dr. Choi. For patients post-radiosurgery who develop vestibulopathy or dizziness, at what time point after radiation are we seeing those symptoms appear? And then perhaps offer up an opportunity to discuss interventions for resolution.
So I've seen it in both conditions, like both early after radiosurgery and also months, but I would say typically in the months after radiosurgery at the 6-month follow-up, sometimes associated with increased enlargement and then some resolution subsequently with follow-up. I think there's some interventions, some interesting data out there about maybe contouring you know, the vestibule to see if maybe doses can correlate to areas. So I think there is some interesting data showing that maybe dose reduction to these areas might be able to reduce some of the symptoms. But again, I think there's additional studies that need to be done for that.
Maybe if I can chime in here as well. Sorry, I keep talking. But yeah, I think there's pretty strong data in the neurology literature that correlates cochlear or labyrinthine dose with the incident and the prevalence really of these vestibular you know, issues. As neurologists, again, we do see all these patients back, and they knock on the door. You know, oftentimes we need to you know, perform gentamicin injections. Really quite aggressive physical therapy, and we had some folks who have had falls and subsequent, you know, comorbidities from that. So it's something that it can be quite persistent and bothersome for patients. It's not really well described in the literature to the extent that we see clinically. I would think that with jugular foramen tumors, it's definitely higher, just because of the site of the radiation and the radiation fields. But certainly we do see it with acoustic tumors as well.
Very Very good. We have another panelist from this afternoon, Dr. Cameron Wick, who had a question for Drs. Choi or Lunsford. Do you have any comments or experience on a frameless gamma knife option? I'm not sure, Dr. Wick, if you're referring to the Esprit frame that Dr. Choi was describing earlier. But for Drs. Choi or Lunsford, do you guys have any comments on that experience?
Well, the answer is, in short answer is no. I believe that in order to be able to do this in a single session with high precision, that it requires a frame-based approach. And so we have not gone that pathway. One of the sales point for one of the other competing technologies for years of this was a video in which a patient is having a frame put on their head and they're screaming and yelling and crying and tears are coming down their eyes, and it looks like some kind of barbaric type of procedure, and we just don't do it that way. So I think that the argument for using a mask because patients think actually, in our experience in using a mask, which we do a lot of in terms of other indications, not for skull-based tumors, but for other intracranial tumors, about 20% of the patients can never tolerate a mask because of the claustrophobia related to it, and another 20% of the patients have to be tracked continuously to look at potential movement, and then have to be recone beamed periodically to solve this particular issue. So the frame gets rid of all of that, so yes, it can be done, but I don't think that that's the proper process of going in. And maybe it's also my bias is that as soon as that happens, then you don't need the neurosurgeon anyway. You don't need the neuro-otologist anyway. Who do you need? You need a machine and a radiation oncologist and a medical physicist, and you're good to go. And trust me, across the United States, that's what's happening. It's happening everywhere. So we can argue amongst ourselves as professionals is what we can think. But I can tell you in the community, there are hospitals getting fractionated radiation therapy with a LINAC with a mask for acoustic neuromas, and that data ain't going to ever be seen.
And I'm just going to follow up with that. So we were just talking about this, this is a, conservative healthcare environment. Everybody wants to save the money. Gamma knife is a expensive tool with source replacement. How do you convince a hospital to, buy into that? When they buy a LINAC, they can use it for multiple different things, versus here we have a gamma knife technology that only for certain. Have you looked at the financial aspects of this, and how do you convince a hospital to invest?
The answer is yes. We have done this repeatedly over 37 years, which is why we've put in 7 different editions of the gamma knife over the course of time and have treated over 18,600 patients. The return on investments for hospitals basically starts at 100 patients a year. If you don't got 100 patients per year, you shouldn't buy a gamma knife. The return on investment is dramatically increased between 100 patients a year and 700 patients a year, as we do. As you know, in going to the local hospital administrator, the only thing they're really interested in is their return on investment. They're not really interested in patient outcomes or what's good for the patient or anything. They're only interested in the bottom line. Yes, and as Lexell said 70 years ago, when you're doing brain surgery, the precision of your device should be considered fairly important. And we use a lot of expensive toys in our regular neurosurgical world. None of these very cheap. When you go to the general surgeon and they want the next $3 million Da Vinci device, there's got to be some return on investment to sell it to. the hospital administrator. But the data is the data is out there.
I think you touched on this, Dr. Lunsford, and Dr. Choi. I think you also had mentioned this as well, but with the ability to do fractionated treatment and with the increasing data that we have on equivalent biologic doses for appropriate fractionation schemes for many tumors, both benign and malignant, can you comment on scenarios where fractionation would perhaps be preferred, or in what situations you would actually use that approach as opposed to single fraction, with the understanding that, as you said, that that's happening literally all over the country with folks like tools like CyberKnife, and then perhaps discuss the fractionation schemes that you would use in those scenarios that you would use that technology.
So I can comment on that. I think, so I would say a lot of what drives the data for, centuries worth of data of the advantages of fractionation, have to do with the 4 R's. And many of those R's are not really relevant to fractionation for a vestibular schwannoma, a tumor that is very slowly growing, where sublethal damage repair and, fractionating and allowing repair between of the normal tissue surrounding in order to increase that therapeutic ratio between the tumor response to the surrounding tissue. It's not really as relevant to SRS, but there are certain cases where I might consider it. Very large tumors, patients who can't tolerate a frame would need a mask, and with that increased setup uncertainty, you might want to add a margin, which then would make your volume even a little bit bigger. And I think there's comments about Gamma Knife as a, I think at the end of the day, the reality is not every center is able to have, a Gamma Knife machine. You do the best with the machine that you have. And what's more important driving that is the experience of the person treating you and their expertise. So I think in certain scenarios, fractionation could be beneficial, although most of the data that's reported out there is for single fraction. And I think the radiobiology benefits of fractionation, I would say, are not as advantageous, but I would be interested to see the long-term results that are being looked at.
Great. There was one more question from our participant, and then we'll go to break. Can Gamma Knife be the first treatment option for a patient who has no issues other than hearing loss exceeding 40 millimeters?
Well, I think in general we prefer to use volume rather than single dimension measurements to describe a tumor. I think the issue is not what the MRI scan looks like, as I mentioned. The issue is what the patient looks like. What are the patient's clinical symptoms? Does this patient have a clinical mass effect associated with imbalance, ataxia, headache, cranial neuropathy progression? Then I think that radiosurgery as a first line option for that patient is not as good. On the other hand, we've shown you data related to 90% tumor growth control rates with tumor volumes up to 10 cc's anyway, with very good long-term outcomes. And certainly we've treated tumors that are bigger than that, but the results are not as robust in those tumors. And that's why the option in some patients is a subtotal resection with a goal of cranial nerve preservation, and then adjuvant radiosurgery as a cleanup hitter in a certain group of patients in that scenario.
I have one more question, probably for Dr. Bishkaya, Dr. Lunsford, and Dr. Cystic tumors, they're not, and I think Dr. Adamka touched a little bit on it, they're not as radiosensitive compared to others, at least like a different kind of cystic tumors. Is there still a data or role for radiosurgery, or are those better for like surgery?
Well, as I showed you in our data, that message on the street that cystic tumors don't respond was in fact incorrect, that the cystic tumors are much more likely to shrink after radiosurgery than the non-cystic tumors. And that includes those with both microcystic change as well as macrocystic change. So from a standpoint of selection of strategy, I don't think that that finding in the imaging studies is a part of the decision making.
Personally, I haven't observed any difference radiating cystic versus solid tumors. Stereotactic radiation is effective in both, in my opinion. Surgically, there's another notion that cystic tumors are more difficult to resect. They are more adherent to the cranial nerves or vascular structures. I find that 50-50 again, and some tumors are very easy, some tumors difficult. And we look into that and we published a paper about it. So facial nerve outcome was same in both groups, solid versus cystic. And when you define the cystic also, there's many different ways of defining cystic tumors, like at least volume-wise should be 50% or more cystic, in my opinion. There are some tumors with the little cyst that doesn't mean anything.
No, I would second that. I would maybe add that, and I had it in my slide, that our view that cystic tumors are probably more of a surgical indication, at least in my practice, is because not that they're less radiosensitive, but rather that they show more post-radiation swelling.
And observing them also, in my opinion, is not good. Either you radiate or do surgery. Observing, following them, just they can expand suddenly. And I've seen so many of them over time, even small ones. So I think if you want to choose the observation, I will choose the small, solid tumors over the cystic tumors.
Yeah.
I think one thing to differentiate is the tumor with intratumoral cysts versus a patient with a tumor with a trapped cistern. And they can be a trapped cistern posterior to the tumor or trapped cistern anterior to the tumor. And those can be problematic. But what I'm talking about is intratumoral cystic change, not trapped cistern.
Yeah.
Good. Well, I can't thank our participants on the panel enough for just a fantastic and eye-opening morning into this world of vestibular schwannoma that I think is still clouded a little bit in some uncertainty, but I think you guys have helped provide our audience with some pathways going forward for management of our own patients. It is really my pleasure to introduce our next speaker. Lexi Miles is a vestibular therapist at Froedtert in the Medical College of Wisconsin, where she's been practicing since 2008. She received her physical therapy degree at Marquette in 2004, and personally have had the distinct pleasure of working with Lexi in the care and management of multiple patients with vestibular schwannoma. She's an excellent clinician and a co-investigator on a trial in the Medical College of Wisconsin that she'll be discussing with us today, exploring the concept of prehab instead of rehab in patients with surgery or radiosurgery for vestibular schwannoma. So Lexi, thank you so much for joining us, and welcome virtually to Madison, and hopefully our paths cross again in Milwaukee sometime soon.
Okay, thank you for that introduction, Dr. Bovey. Just gonna make sure that I'm sharing my screen here. Okay, can everybody see my slide?
You're all set. It looks great.
Great. So I'm really excited to have been invited here today to provide a perspective on vestibular rehab for patients with vestibular schwannoma. I've been working exclusively in this area of physical therapy for the past 16 years. Over those years, there has been considerable advancements in the approach to rehabilitation for patients with dizziness and balance dysfunction. Today, I'd like to start off by giving an overview of what vestibular rehab is and the types of exercises that we utilize. and then discuss the state of the literature in regards to the use of vestibular rehab for patients with vestibular schwannoma, and then finish with a description of the program that we have developed within the ENT, neurosurgery, and radiation oncology departments here at Froedtert and the Medical College of Wisconsin for patients undergoing treatment of vestibular schwannomas, and specifically describing the study that Dr. Bovey alluded to. So I have no conflicts of interest to disclose. Okay. So vestibular rehab consists of specialized exercises designed to improve patients' function by helping to improve their ability to see clearly while moving, so improving their gaze stability, as well as improving their balance, postural stability, and gait stability, in decreasing their reports of dizziness with movement. These exercises are individualized to each patient in order to address their specific limitations and symptoms. Oops, too many. Okay, so gaze stabilization exercises are exercises that are prescribed for patients who have reports of visual blurring with head movement. Okay, so specifically, these patients would report difficulty with being able to see clearly while they're moving. They'll often describe their symptoms as feeling like their eyes lag behind their head movement or don't stay caught up with their head movement while they're in motion. These patients would present with an impairment of their vestibular ocular reflex as seen with a positive head impulse test or with an impaired dynamic visual acuity. So examples of gaze stabilization exercises that we use are, first here I'll show you a video of VOR ×1. With VOR ×1, the patient is asked to focus on a stationary target as they turn their head. And they're asked to turn their head at a speed that they can still clearly see the target, and then gradually try to go as fast as possible as long as that target stays stationary. So if they start to get a jumping or movement of the target, instructed to slow down. VOR ×2 is similar to VOR ×1, but the target is now moving the opposite direction of their head movement. And another exercise is a 2-target VOR, where the patient is presented with 2 targets. They're first asked to look at one target and align their head to face that target, and then asked to quickly move their eyes to the second target and then turn their head to align with that target. So the goal of these exercises is to help improve the patient's ability to maintain stable vision. And this is accomplished through a number of different mechanisms. One of those mechanisms is through adaptation. And as the patient turns their head during these exercises, there's a retinal slip that occurs as a result of their impaired vestibular ocular reflex. And that retinal slip or visual blurring is the error signal that the brain uses to drive an adaptive response to the VOR gain. Another mechanism through which these exercises help is to the use of substitution. So we're trying to train them to use other eye movements, other ocular systems such as visual tracking, saccades, and the cervical ocular reflex, and train those up to substitute for their impaired vestibular ocular reflex. And then another mechanism these exercises help is through central pre-programming or a neural remodeling of how the brain is maintaining gaze stability. So it has been shown that there can be over time an initiation of a compensatory saccade, and that the speed that these compensatory saccades are initiated can be increased through the use of these exercises so that that saccade is occurring as the head is in motion. Okay. In addition to gaze stabilization exercises, we also use habituation exercises. And these exercises are used for any patient who is reporting symptoms of dizziness that can be triggered by their movement. So if they're turning their head quickly or changing positions, as well as people who report dizziness triggered by movement of the visual environment around them or being in busy visual environments such as scrolling on their computer or phone, or walking down a grocery store aisle, scanning the shelves, or in large crowds of people while people are moving past them. And due to the asymmetrical vestibular input that they're receiving, or a conflict in the visual and vestibular information that they're receiving, this leads to a sensory mismatch, which is interpreted as dizziness. So by having the patient perform movement or activity that triggers their symptoms, we are providing them with a provocative stimulus or a trigger. And with repetitive exposure to that stimulus over time, this will result in a gradual reduction of their dizziness. So when prescribing habituation exercises, it's always best to start with just 2, maybe 3 at the most movements that are moderately provoking of their symptoms. I don't want to start them with the most intensely triggering symptoms because I want them to be compliant with the exercises. So, try to start off easy and then progress over time. But when I'm instructing them on these exercises, they're to do a few repetitions, enough to trigger, maybe a 2 to 3 out of 10 point increase in their dizziness, and then wait for the symptoms to resolve or subside back to their baseline before doing another repetition. And the goal is that over time, they are going to see a reduction in their symptoms. Now, I'll often hear from patients that they did vestibular rehab, they tried it, and it made them feel worse. So, they stopped. And when I dive a little bit deeper into that, they'll say, well, they went to one visit, they went home, did the exercises, they felt worse, so they stopped. And that's normal. If you do something that makes you feel dizzy or makes you feel worse, as a protective reaction, you're gonna stop doing that. But I found that taking the time to really educate patients on what to expect with these exercises and knowing that initially they're going to feel worse. And that could, be the first few days, first week or 2 of doing the exercises. But if they try to stick with it and push through it, it is going to get better. So a lot of time is just spent on educating the patient about what to expect as they're going through the therapy and really trying to coach them how to do these exercises and to keep going with them. So we should expect that they should see a reduction in their dizziness within, definitely 2 to 3, 4 weeks of doing these exercises. So balance problems and unstable gait are other common symptoms that are experienced by patients with vestibular dysfunction. And these problems are addressed by working on balance and gait exercises that focus on helping to improve their use of vestibular cues for balance. So typical exercises we'll use with patients is having them stand on uneven surfaces, such as a foam pad or a rocker board, and having them do eyes closed or head movements, tossing, catching a ball, so that they are able to rely less on their somatosensory and visual cues for balance and try to strengthen how well they're using their vestibular cues. We also try to just vary the environment that they're doing these exercises in, and progress to having them do them in busy visual environments to help promote optimal sensory organization and having them learn to use their different sensory cues optimally. So moving on to what the literature says as far as outcomes for vestibular rehab. There's evidence that vestibular rehab can improve patient symptoms of dizziness and balance dysfunction post-surgical resection. So this study that was published in 2020 by Miller and colleagues looked at 19 patients who underwent surgical resection of their vestibular schwannoma. And they had them initiate these vestibular exercises 6 weeks post-resection. And what they found is they used a combination of gaze stabilization as well as static and dynamic balance exercises. And their results after having the patients perform these exercises daily for 5 weeks, as well as going for a daily walk, that the patients had an increase in their gait speed, as well as improvement in gait stability as measured by the dynamic gait index. And they also reported subjective improvements in their dizziness and improved balance with confidence and improved balance confidence. They also had some improvements in their dynamic visual acuity as well. In 2012, there was a systematic review published looking at vestibular rehab after surgical removal of surgical resection of vestibular schwannoma. And they identified 6 randomized controlled trials that evaluated vestibular rehab interventions. These interventions were provided to patients, 3 studies just acutely, so within those first 2 weeks after surgery. And then subacutely, there was 1 study looking at vestibular rehab post-op up to 12 weeks and another one up to 8 weeks. And so there was, considerable variability in the time frame that these vestibular rehab exercises were administered, as well as some variability in the type of exercises that they used. But the main takeaway from this systematic review was that the more customized or individualized program was, and a combination of gaze stabilization, balance, and habituation exercises, they all reported positive findings with a reduction in reported dizziness and improvement in static and dynamic balance function. So I was unable to find any studies that look specifically at vestibular rehab post gamma knife. So this is definitely an area where there is opportunity for further research. Okay. The number of patients that could potentially benefit from vestibular therapy is quite high. There's a large multi-center study of 538 patients that found that about 50% of patients report dizziness prior to their surgery or radiosurgery treatment. And for those patients who do undergo treatment, about 60% of them experience long-term dizziness up to 8 years after treatment. A number of different studies that have looked at the factors that can contribute to persistent dizziness with vestibular schwannoma, and there have been a lot of varying findings. But across the majority of the studies, there were 2 factors that were consistently identified as contributing to long-term dizziness post-treatment. And those factors were the presence of pre-treatment dizziness, as well as pre-existing headache and migraine. So there have been a few studies that have examined the effects of physical activity in general on the recovery of balance and dizziness post-surgery. This first study looked at a group of sedentary and physically active patients, and they found that the group that they classified as sedentary took a longer time to recover post-surgery and had a greater decline in their static balance control acutely after surgery. And they defined physically active patients as patients who had regular participation in sports or physically demanding activities such as high-level gardening, carpentry, or factory work. Another study found that patients with chronic dizziness, and they define chronic dizziness as persistent dizziness at 6 months post-op, that these patients had lower levels of physical activity and poorer balance performance when tested at 9 weeks post-op than those who did not go on to become chronically dizzy. So this suggests that there may be an association between the level of physical activity and the development of chronic dizziness. A conclusion that was drawn is that regular physical activity before surgery can help to promote neuroplasticity, which allows patients to recover faster, achieve quicker benefits when participating in therapy after surgery. So it may be helpful to expose patients early on to vestibular rehab so that they can be educated on the benefits of increasing their physical activity, as well as instructed on how to participate safely in exercise and in order to maximize their activity both before and after surgery. So a few years ago, I approached our ENTs with the idea of potentially referring all patients for at least one pre-op visit of vestibular rehab, with the idea being that maybe it may help improve their recovery both post-microsurgery and post-Gamma knife. So that led over the last few years to our developing a study where we have actually just started currently enrolling subjects to try to answer this question. Could vestibular rehab prior to their treatment affect their outcomes as far as balance and dizziness post-treatment? So for our program, they are referred for a pre-treatment vestibular rehab eval 6 weeks prior to the date of their surgical resection or Gamma knife therapy. And during this initial evaluation, we are taking a subjective history, very comprehensive subjective history, as well as obtaining information about their dizziness and balance confidence using specific outcome measures. Basic ocular motor exam, including a head impulse test. We're also performing computerized dynamic visual acuity, as well as looking at their gait stability with the functional gait assessment and their static postural control with the sensory organization test. And the patients who have been randomized into the arm where they're receiving the pre-vestibular therapy exercises are then also instructed on exercises that they will perform daily for at least 5 weeks prior to their treatment. So just want to briefly go over some of these outcome measures that we're using. The Dizziness Handicap Inventory is a self-report questionnaire. The patient answers 25 different questions to evaluate the effect of dizziness on their function. So the measure is scored on a 0 to 100 scale, with the higher score indicating the higher self-perceived disability from the dizziness. The MCID for this measure has been shown to be an 18-point change from pre to post treatment. The Activity-Specific Balance Confidence Scale, or ABC scale, we use to evaluate their confidence with balance. So they answer 16 different questions where they are asked to rate their perception of confidence when performing activities such as walking around their house, walking up and down stairs, doing more ambitious activities like sweeping the floor. The patient will then rate their confidence as anywhere from a 0 to 100% confidence. 0 indicating they have no confidence that they can keep their balance when doing that activity, all the way up to 100. And this score is averaged, and it's been shown in patients with vestibular disorders that a score of less than 67% is indicative of an increased risk for falling. Computerized dynamic visual acuity is a test that we use to evaluate the function of their vestibular ocular reflex. So they are asked to identify the direction of an optotype that's displayed on the screen. We do the test first with their head stationary to get a static baseline, and then they're wearing a head sensor on their head that measures the speed and amount of head movement. So the test is then repeated with their head turning, and they're asked to identify the direction of the optotype. So with this test, we're able to get scores for head turns to the right and the left side. This test can also be performed non-instrumented using an ETDRS eye chart. And we get a score for this test in terms of the number of line different that they can see with their head turning versus head still, or number or logmar number. And so a loss of 3 lines or more, or a logmar change of greater than 0.2 is indicative of an impairment in their functional ability of their vestibular ocular reflex. So the functional gait assessment is a 10-item test where they are asked to do different activities such as walk while turning their head, walk with eyes closed, tandem walk, and it's scored on a 0 to 30 points scale. The higher score, the better. The MDC for patients with vestibular disorders is a change of 6 points. In the sensory organization test in our clinic, we use the Vertex system to perform this test. Is used to evaluate their postural sway. It records their amount of anterior posterior sway under 6 different conditions. And this gives us information about how well they're able to utilize their visual, vestibular, and proprioceptive cues for balance. An average composite equilibrium score is given for their results, and a change of more than 8 points is the minimal detectable change to show improvement. Okay. So those patients that are randomized to the prehab arm are then instructed on a combination of exercises. So they are instructed on gaze stabilization exercises that they are to perform 3 times a day for a total of 20 minutes throughout the day. And this amount in time came from the clinical practice guideline for treatment of vestibular hypofunction. They're also given habituation exercises if they are reporting dizziness with head movements or position changes, as well as balance exercises like eyes closed, standing on foam, single limb stance, and tandem stance. And then instructed to either do a daily walking program or biking, stationary biking, swimming, anything to just provide some aerobic conditioning as well. If patients do have vestibular symptoms prior to their surgery or gamma knife, they are seen up to 3 visits to help progress their exercises and work on their balance and limitations. And then they're also, at home doing these exercises on their own daily. After they have had their gamma knife or surgery, they are then seen for vestibular rehab again at 1 week, 6 weeks, 6 months, and 1 year. And all of those outcome measures are repeated at those time points. They may participate in a few more visits as well, if necessary, to help address symptoms of persistent dizziness or imbalance. And they're instructed to perform their home exercises every day for at least 12 weeks. So while we don't have the answers yet to the question of does prehab help, as we just started this study, some of the takeaways that I have is that comprehensive history taking may help identify pretreatment factors that could impact post-treatment outcomes. Having them undergo this initial vestibular rehab appointment can provide a baseline assessment of what their dizziness, functional assessment of their VOR, postural control, and gait stability. And patients who have vestibular schwannoma, it might be assumed that the dizziness or balance problem they have is due to the tumor. But just like the general population, there can be other things going on that may be causing the dizziness that they're experiencing. So having them go through this comprehensive exam could help identify other medical issues or other causes of dizziness that need to be addressed. Initiating these vestibular exercises prior to their treatment modality may help lay a framework for central vestibular compensation so that their recovery after the intervention may be quicker. And then it just gives us an opportunity as well to educate the patient on the benefit of increasing their physical activity prior to and after treatment. So as the literature shows, the more active they are, the less likely they are to experience chronic dizziness and balance dysfunction. And just wanted to close with this slide. So how can you find a vestibular therapist near you? So, not all physical therapists provide vestibular rehab or have the same experience with vestibular rehab. So this website is provided by the Vestibular Special Interest Group from the American Physical Therapy Association, and you can go there, click on your state, and find a list of vestibular therapists near you. Okay, here are my references. All right, and thank you. I want to thank Dr. Bovey for giving me this opportunity to present to you today.
Thank you, Lexi. That was a great talk on something that's very important for our patient, which is quality of life and preserving their function. And that leads us nicely to what Dr. Welling would be talking about is NF that significantly alters patients' quality of life. It's my great pleasure to introduce Dr. Welling, who is internationally renowned for his work on management of vestibular schwannoma in the context of NF2. Dr. Welling is Walter Augustus LeCompte Professor of Otolaryngology at Harvard Medical School. And Dr. Welling's research efforts primarily focuses on NF2-associated vestibular schwannoma and the hearing loss, disequilibrium, and facial paralysis that may result from this disease. So it's a great pleasure to invite you, Dr. Weller, and thanks for being here.
Thank you very much. It's a great honor to be here. I've enjoyed the presentations thus far. Thank you.
Okay, just let me know. Just say next slide, please.
Okay, thanks so much. Next slide, please. I appreciate so much being asked to participate in this great conference. I have no relevant financial disclosures. Next. I'd like to talk today for a few minutes about NF2-related schwannomas, and I'll try to touch on 5 different points: predicting tumor behavior, timing of intervention, hearing conservation, and small molecule inhibitors, and just a brief moment on gene therapy. First of all, next slide, please. I think a number of different studies have looked at trying to predict tumor behaviors, and most of the efforts have not been too successful. Next, please. It's known that there are a number of different pathogenic variants in vestibular schwannomas in both NF2-associated tumors and sporadic tumors spread throughout the 17 exons of the NF2 gene. And the one thing that has been shown to help with predicting tumor behavior in NF2 at least is genotype-phenotype correlation. Next, please. There have been several nice studies that have been done looking at this. I think that the studies agree that if the patient has a mosaic mutation, meaning they don't have the mutation throughout all the cells of their body, but just in selected cells, they have a milder manifestation of disease. Likewise, if they have complete absence of the gene, either from a truncated mutation or whole gene deletion, they're much more likely to have severe mutations, a severe phenotype. There are a number of other types of mutations, missense mutations, splice site insertion deletions, and so forth, that are somewhat dependent on their location, and the different groups vary in terms of their opinion about these. We're actually reviewing our 336 NF2 patients right now to see if we can clarify this at all. Next, please. This is a nice genotype phenotype severity correlation that Dr. Halliday did from the UK group. And one of the strongest associations is the mean age of diagnosis and age of first treatment, but all these other tumor burdens scores certainly are related, and even hearing grade is related to the underlying mutation. So knowing what the mutation is in NF2 may be useful. Another thing that we've looked at, next please, that we've been looking at recently, and I think others are studying also, are there serum biomarkers that predict tumor size or hearing status in patients? In sporadic vestibular schwannomas, in the first study listed here, we looked at 170 sporadic schwannomas and 66 different immunologic markers. And we found that there were some markers that were related with tumor size, particularly S100B, which is a calcium binding protein in the serum. And if the tumors were expressing eotaxin, that also significantly enhanced the size of the tumor. Likewise, hearing decline correlated with levels of a monocyte chemotactic protein, and the pure tone averages decreased when there was tumor secretion of IL-16. So these biomarker studies need to be repeated in NF2 specific tumors and serum, but there is indication that maybe that will aid us in terms of predicting tumor size and hearing. Next, please. Can either of these help us in terms of treatment recommendations? Well, let's look at a couple of case studies. Next, please. First case is a baby who was born that had noted skin lesions soon after birth. Other neurological symptoms included head tilt and strabismus, increased head circumference. At about 18 months, he had skin biopsies, which were consistent with plexiform schwannomas. And by 24 months, he had an MRI and genetic analysis that showed he had NF2. He had a complex duplication of exon 12 and deletion of an adjacent exon 13, predicting that he would have a severe phenotype. Next, please. Here you can see his at 2 years of age, he had tiny lateral internal auditory canal tumors, the one on the right being slightly smaller. On the coronal, you can detect that it's on the superior vestibular nerve, which portends greater likelihood of hearing preservation. On the patient's left, you can see 2 tumors in the internal canal, which is not at all unusual. At this point, we recommended surgical excision of the smaller tumor on the right. The parents got conflicting opinions from a number of different folks, including our neuro-oncologist and the neuro-oncologist at their local institution. And we waited. Next scan. Next slide. So at 4 years, you see the tumors have grown. They're not growing rapidly, but they are growing. And on the coronal now, you can see 2 tumors in the right internal canal, as well as the confluent tumor on the left. Next, please. At age 5, the tumors continued to grow, and parents decided at this point that section would be a reasonable consideration. They had also been recommended to try several different drugs. Everolimus was one, and lapatinib another. But they went to another institution, had left middle cranial fossa excision of the tumor. Next slide. The ABR was preserved until late in the case, and then it was lost, and the hearing was lost. And then the patient underwent a left cochlear implant because the cochlear nerve was saved. The right tumor continues to grow, but he is doing well with his cochlear implant at this point and getting good response from it. Next, please. So I'd like to make a couple of points on this case. I think that, first of all, these are all difficult decisions. There's not a single NF2 patient that has easy decision making, and I don't fault the parents for turning down my suggestion, even though it was the best one. I think that when the treating teams and physicians can come to a consensus that makes it easier for the parents in treating children, but that's difficult. I do think that in this case, we knew that the severe phenotype was predicted by his genotype and also his very early age of onset. And I do think really that had he been able to undergo a tumor excision as I had recommended, that we would have had a much higher likelihood of hearing preservation with such a tiny superior vestibular nerve tumor on the right. We would have taken out both vestibular nerves at the time to prevent later formation of inferior vestibular nerve tumors. There was a higher likelihood of complete tumor resection and a higher likelihood of cranial nerve preservation, even if hearing was lost. And it would have possibly allowed us to go ahead and take out the tumors on the opposite side as well. At age 6, with incomplete resection in the left vestibular schwannoma, there's a little bit of residual, I think you can see on that last image. I think he's doing well with his cochlear implant. His ABR is still normal, even though the right tumor is continuing to grow. But these are complicated decisions. Next. I think that this case is quite different in that this woman presented at age 31. She's an interstate truck driver. Truck Angel is part of her email. She's a wonderful young lady. She presented with hearing loss and was diagnosed with NF2 by MRI. And in 2012 underwent a right vestibular schwannoma excision. At the time, she had 76% speech discrimination. The left ear was larger. Her genetics have been done but are unknown. I'm trying to track those down right now. Had a near total resection of the right CPA tumor and a small tumor that was located lateral in the internal auditory canal, but we knew that her cochlear nerve had been preserved and her facial nerve did well. The tumor on the opposite side continued to grow. And next image, please. We waited over the next 9 years as her hearing continued to deteriorate in her left ear, which was her only hearing ear. Next slide. At this point, her tumor was slowly enlarging. It was not rapidly enlarging. You can see the small residual in the right internal auditory canal. And the left tumor with no hearing, we decided would be best to remove. Next. So she had it done through a translabyrinthine approach. The tumor was totally resected and her facial nerve function was good. And then, as you can see from the defect on the MRI, she did have a cochlear implant in the right ear because we knew we had preserved her cochlear nerve. Next. This is the response to her cochlear implant. The C's represent near normal thresholds in her cochlear implant. She wears it 8 to 14 hours a day and is making progress with her cochlear implant. Next. Next. Yeah. So the points from this case, I think that following the excision of her right tumor and the loss of her hearing, we had no opportunity for a hearing preservation approach in the left ear, which was her only hearing ear. So we were able to wait for 9 years. I think she has probably a less aggressive mutation. Not always will brainstem compression allow this, even if hearing's still functional, as I'll show you in a minute. She declined the ABI based on the fact that many people find that it's not as helpful as they would like, and she wanted to try the cochlear implant. But about 50% of my patients who have auditory brainstem implants use them regularly. Our audiologists tell me that overall at Mass Eye and Ear, about 75% of patients with ABIs use them. I do think that talk-to-text apps, such as they can put into Google Glasses and that sort of thing, particularly with AI Assist to help localize sound, will be something very useful going forward. And one of my NF2 patients is working on that particular application. Next. So timing of intervention can be really important, or lack of intervention. And I think that we hope to have better handles on how to do this. But let me show you one other case. Next. This is a 9-year-old boy who came in with a family history of NF2. And so at an early age, at age 9, he had small tumors detected in June of 2018. And you can see by May of 2020, they've grown a little bit, not a lot. Next. Auditory brainstem response tests can be helpful because although his audiogram was normal at this time, you can see that on the left side he had delays in wave 5 or wave 3 and wave 5, meaning there's a loss of electrical conduction efficiency through the cochlear nerve on the left. So we elected to resect the right tumor first, given its normal ABR. Next. And so the arrows pointing to the pre-op, and on the right image, the post-op, you can see a tiny bit of residual tumor. Next, please. And here's his pre and post-op audiograms, which were fortunately very similar. He continued to have 100% speech discrimination on the left and 98% on the right following the resection. Next. I think that somebody earlier alluded to this. I think our treatment inclination curves in NF2 follow along with small tumors. I prefer to operate on them early when we have a chance of saving hearing or saving the cochlear nerve for cochlear implantation. When tumors are mid-size, our likelihood of saving hearing is much less, and we tend to increase the use of temporizing medications such as bevacizumab. And when tumors are squishing the brain stem, we're more likely to take them out. In yellow, maybe you can't see this, but on the bottom, I think there's a role for radiation in NF2-associated tumors. I'm sure Dr. Lunsford would say we should use it more than we do, but I would say there really is a place, and we tend to prefer it in patients who are older. We don't like to do it in younger children and patients who have failed surgical treatment and need adjunctive radiotherapy. Next, please. So how much longer can you wait and watch? This is a 22-year-old woman that we have that has NF2, has had the right side resected with no hearing, and a left tumor that's been slowly enlarging over a number of years. It does grow 1 millimeter or 2 in dimension, and volumes increase every year. And you can see her audiogram on the left, which has exactly perfect hearing in the left ear. She's graduated with a master's degree. She's a very bright young lady, and she's doing everything she can to avoid losing her hearing, as are we. She takes a number of different medications, including bevacizumab, brigatinib. She's on aspirin, and she's probably on some pharmaceuticals that I don't know about. But when do you take this out? I don't know. But I'm worried that when it occludes her fourth ventricle, and we might have an acute problem on our hands. Next. So the trends in treatment in NF2 have changed over the last couple of decades because of the introduction of bevacizumab. You can see a gross uptick in the number of patients who are getting bevacizumab, and downtick in surgery, a little downtick in radiation as well. Next. What about the difference between a cochlear implant and auditory brainstem implant? For auditory brainstem implants in 66 patients that were reported by Steve Otto at the House group a number of years ago, they found that 12% of patients had some open set speech understanding, meaning when they have no lip reading, 12% of them could understand some words. They did find that the sound was enhancing for lip reading, and it helped with environmental sound awareness. But our response had been much better when we were able to save the cochlear nerve anatomically, and were able to put a cochlear implant in. Next. In a small retrospective study of 6 patients, we looked at the open set speech discrimination. You can see CID sentences in the third column, and they weren't obtained on the first patient, but the next 5 patients had them obtained. And one patient only got 22% in open set speech, but the others did very well. And 5 out of the 6 in the far right column, you can see, are able to use the telephone at an average follow-up of almost 9 years. So we think that if it's possible to preserve that cochlear nerve, it's a good thing to try to do. Next. Another thing that has come to my attention just in this past year, and some of you may be well aware of this, is that I've always had a problem with the way that we monitored hearing intraoperatively with ABR, because there was such a delay between the recordings of the signal and what was happening surgically. It usually took a minute or 2 to get enough sweeps to get a good signal. But with direct eighth nerve monitoring, I think that we can show an actual improvement in this. And Dr. Nakatomi from Japan and Dr. Sass from a group in Denmark have shown that this extended retrolabyrinthine or transcondylar approach, where they go in and come through the dura down near the foramen magnum, they're able to put a continuous facial nerve monitor near the root entry zone of the facial nerve, and also slip an electrode into the fourth ventricle and monitor the dorsal cochlear nucleus with real-time monitoring. This increased the serviceable hearing to 70% and 77% in the Danish group, up from 50% prior to using this technique. Next. At the foot of the bed is a large monitor that has a trending graph. So the upper two traces are for facial nerve stimulus and response, and the lower two are hearing. And whenever they see a dip in the hearing or the facial nerve response, the surgery is paused and wait until there's recovery. And on a very large, or not a very large, but on a moderately large cystic tumor that you see on the right, the patient had preservation of hearing, which I think was quite remarkable, given their technique of intracapsular dissection and monitoring for change in the adjacent cranial nerves. The green paddle in the middle is the electrode they put into the fourth ventricle. Next, please. The postoperative result shows a small rim of capsule that's remnant that persists, but his hearing and facial nerve function was excellent. Next. Next, yeah. So let's shift hats for a minute. I think that it's common knowledge that we're not going to cure a genetic disease with a knife, so we need to think of other ways to try to do it. And next, over the years, a number of different trials have been completed looking for NF2-related schwannomatosis response. Next. I can group these into three categories, basically. One group looked at epidermal growth factor and ERBB2 inhibitors. Next slide. A big group looked at mTOR inhibitors, everolimus particularly. And next. And another group looked at vascular endothelial growth factor inhibitors. And of the three main groups that have been looked at, I would say the latter is the most successful. Next. Just a word or two about bevacizumab or Avastin. It's a monoclonal VEGF inhibitor. It's used off-label. It's not FDA approved, and there have been both retrospective and prospective studies done. About 35 to 40% of patients show hearing improvement, which shocked me. I didn't believe it at first. 32 to 55% showed reduced size in the schwannomas, and 61% that preserved hearing had hearing stable at 3 years. Unfortunately, it's much less effective in children for some reason. Kids less than 21, it does not work nearly as well. And hypertension and proteinuria are common side effects that occur in about 50% of patients by 2 years. I'll also just mention parenthetically, we've had a couple of patients that were on long-term bevacizumab that came off bevacizumab 6 to 8 weeks pre-operatively, but we had a great deal of intraoperative bleeding where it was very difficult to coagulate the tumors. And some of our colleagues, other institutions, have tried to use preoperative embolization when they bumped into this problem, but I'll just mention it as a possible side effect of something that we're going to see. We're trying to figure out why this has occurred, but we haven't quite nailed it down yet. Next. One thing I will point out, I really like this display of hearing in results. Basically on the y-axis, you see a change in the pure tone average. When the pure tone average goes down, it means hearing is improving. On the x-axis, you see a change in speech discrimination. So positive change in word understanding towards the left is also the desired goal. And you see with bevacizumab that a number of patients moved into the upper left quadrant, which is really quite encouraging, and very few wind up in the lower right-hand quadrant. And although I consider us to have a reasonable amount of surgical skill and expertise, we do wind up with patients in the lower right quadrant more than we'd like. Next. Also on bevacizumab, even though there was only a 35 to 40% tumor volume improvement, you can see that that's measured at a decline in 20% by volume. But there are a number of patients who had tumor that did not grow or minimally were reduced in size. And in that case, I think those patients also should be included in terms of a valuable outcome for the bevacizumab treatment. Next. There are a number of ongoing clinical trials. I'll just mention a couple of them. I apologize for the lack of readability of this slide, but Scott Plotkin is the PI on a basket trial design where patients can come in, receive one drug, all of the tumors that they have are monitored on that drug, and then once the results are known from that, they can go on the next drug, and next drug will be put into the same basket. So it's a continual update of different drugs as they come along and become available. Brigatinib has been completed. Neratinib is under trial, and I think maybe it's almost complete as well. I'll also mention our aspirin study. We have a placebo-controlled randomized trial of aspirin to see if it suppresses growth in these tumors. I think there was an interesting discussion about observation or waiting for a little time before you do anything with this tumor treatment. We are putting these patients on aspirin or a placebo and watching to see if there is some inhibition from aspirin, which in the lab and retrospective studies, there's some evidence to support. I won't go through the rest of these at this point, but let's go to the next slide. I just want to mention gene therapy. I think the thing that we'd all like to do is give them back the normal NF2 gene. Next. In order to do this, I think there's been quite a bit of progress made. We've found that vectors can be created that can contain the NF2 gene. The NF2 gene is not very large. We have shown that pathogenic variants are stable. We've had one patient where we've taken out 5 tumors over the last 20 years, and they all have exactly the same mutation. They don't change. Targeted gene therapy is certainly a reasonable expectation that we'll get to that. Novel AAV capsids can contain those proteins, or the gene for those proteins very well. Next. We've experimented with AAV9 variant capsids in non-human primates and found that they not only express intrathecally, or through the intrathecal administration, they express in the spinal cord and in the cochlear nerve, as well as, interestingly, some of the peripheral nerves as well. And in a mouse model, when we replace the NF2 gene into tumors directly with injection, the phenotype reverses and the tumors shrink. And it's quite remarkable. I thought if we stopped the tumor growth, it would be a win, but in fact, some of the tumors even regress. So we're hoping to get to gene therapy for this disease condition because it's miserable, as you all know. Next. So in summary, next, I'll just say that I touched on a couple of quite different topics. I think that predicting tumor behavior in NF2 can be very useful. Genetic phenotyping and genotyping is useful. We're hopeful to get to biomarkers that will be helpful. The timing of intervention is very highly individualized, but I don't think that it's bad to rule out early intervention for small tumors. And that leads to the third point in hearing conservation. We'd like to save the hearing when we can. Small tumors allow that possibility. Cochlear implants are very much more useful than auditory brainstem implants. And real-time intraoperative cochlear nerve action potential monitoring, I think, increases our likelihood of sparing the cochlear nerve. Small molecule inhibitors is a game that's still in progress. I'd love to see us do as well as NF2 or the NF1 group's done with selumetinib, which is very effective against plexiform neurofibromas. And gene therapy, there are a number of groups besides ours who are working on this, and I hope that one day we'll be talking about how we don't have to talk about NF2 anymore. That's our goal. So thank you very much for your attention. I'll turn it over here. Thanks.
This was just great. Thank you so much, Dr. Welling. I really enjoyed this talk, and definitely from a quality of life perspective, I think all of us have probably taken care of, all of us on this conference have taken care of patients with NF2 and understanding the devastating ramifications of, in particular, vestibular schwannomas as part of the pathophysiology of that disease process. So thank you for sharing your insights on that. That was just great. It's my pleasure to introduce Dr. Cameron Wick next. Dr. Wick is a neurotologist at WashU in St. Louis. Started his medical training at Wright State in Ohio, and then did ENT residency training at Case Western Hospital in Cleveland. I had the distinct pleasure of meeting Dr. Wick in Bergen, Norway, a little over a year ago for the Quadrennial Vestibular Schwannoma Conference that was held in that city. We had a wonderful time, and it was just an honor to have him come and join us here for his presentation today on the intraoperative decision-making for cochlear implantation with vestibular schwannoma resection. So thank you, Dr. Wick, and then also thank you for your incredibly good sense of humor with your amazing Twitter handle. It was fantastic to see that. So you take care, and thank you for joining us.
Thank you. Nice to see you virtually, and boy, what an honor to be part of this panel and really enjoying today's discussion. So let's jump right in. Only relevant disclosure is that MED-EL did support the clinical trial that I'll discuss. We did not get monetary support, but they donated the devices. So I just had to slip this slide in, one to recognize my colleagues, Sid Perham, who's a head and neck surgeon, and Albert Kim, who's a neurosurgeon, because, we've been talking about the irregular growth patterns of these tumors. And I think in future conferences, our discussion is going to be about what's going on actually inside the tumor in this tumor microenvironment. So just keep this in mind, that there are different cells within these tumors. Obviously, they're the abnormal Schwann cells. There's some that are kind of a supportive structure, but then we're finding that there are these immune cells, these myeloid cells that turn into microglia or macrophages, and these are demonstrating an injury growth pattern, and this may be the real cause of why some of these tumors are growing. On to the main topic for my lecture will be hearing loss. It's previously been discussed that this is a benign tumor on the nerve of hearing and balance, and despite our best efforts, the long-term hearing results remain poor in most patients. So roughly 80% will eventually lose that serviceable hearing, and that's regardless of observation or treatment intervention. Now, does this matter when it comes to a quality of life factor? There's obviously a lot of things involved with quality of life, and if somebody has paralysis, debilitating dizziness, headaches, those probably drive this ship. But I think it's interesting that both of our quality of life surveys, the original one being the Pan-Acoustic Neuroma Quality of Life Survey, shows that the hearing loss really is the lowest subdomain, and it makes sense. 95% of folks will present with hearing loss as their primary symptom. This has also been demonstrated by the Mayo Clinic Vestibular Schwannoma Quality of Life Index, and again, when looking at all the different subdomains, hearing loss is quite low, and again, this makes sense based on the natural pathophysiology of the tumor. So it kind of leaves us with a management conundrum. We are recognizing these tumors at an earlier level due to the increase of the MRIs. So these are smaller tumors, and when they're smaller tumors, as has been discussed, this is an opportunity for cochlear nerve preservation. There have also been advancements in the cochlear implant space, with all 3 USA manufacturers having an MRI compatible internal magnet. They're expanding indications from the FDA, including single-sided deafness. We know that patients generally aren't satisfied with the tried and true single-sided deafness rehabilitation options, and this is a cross-hearing aid or osseointegrated implant, so there is room for improvement in this space. And then cochlear implant with tumor resection is feasible. Dr. Welling just touched upon the interesting NF2 cases, but it is feasible. To look back at the history of kind of the feasibility of cochlear implants in the setting of vestibular schwannoma resection. So Dr. Cueva had a failed hearing preservation approach in which the cochlear nerve was thought to be intact, and he ended up doing promontory stimulation, and the patient had some auditory pre-steps from it. So we can keep the cochlear nerve intact and still lose hearing, whether that's trauma, a vascular issue, or trauma, within the cochlea. It may be multifactorial, but that nerve can still carry the signal if it is intact. Dr. Arriaga is credited with the first simultaneous cochlear implant during a translabyrinthine resection, and that was in the mid-90s. And there really wasn't much in this literature because of, for various reasons, insurance approval, but also the limitations with MRI and cochlear implants. In 2017, out of University of North Carolina, they had one of the few prospective studies at that time showing translabyrinthine and simultaneous CIs. But interesting to note that they did not do any cochlear nerve monitoring. It was really just the gross visualization of the cochlear nerve. So that led to kind of one of our initial questions in the feasibility is there a difference between the two kind of approaches to cochlear implantation? There's the simultaneous approach where patient essentially has already lost hearing. So you do a translab, you're looking right at the cochlea, you go ahead and place the cochlear implant after tumor resection, assuming the nerve is intact, versus the what we call delayed approach where there was an attempt at a hearing preservation surgery. The patient lost hearing, but the nerve was thought to be intact and then ultimately underwent a CI. So we did a systematic review on this. Again, there wasn't a lot in the literature at that time, just under 100 patients, and they were divided equally amongst those two cohorts. And, these are some international studies as well. So just broadly looking at were people using their device on a daily basis? The short answer is yes, most of the time. So around 80% were using their device on a daily basis. And then trying to be critical of the literature, were people getting open set speech based on their word scores? And roughly it was 50% of the time with no significant difference between the approach arms. So we concluded from that both a simultaneous and delayed approach are feasible. And that's been demonstrated. There's no outcome differences. The delayed option has some unique challenges to it, but it also allows for promontory stimulation, which confirms that the nerve is intact and can carry a signal. And then, it needs to be acknowledged that there's a lot of bias in, I think, the cases that were reported. So we think of this as kind of the upper end of what we should expect from outcomes in this space at this time. And so when you think about, the timing of these implants, again, a delayed approach brings about potential issues of cochlear ossification, multiple surgeries. You're now opening up, potential for a CSF leak. And in some cases, this is delayed and there's a duration of deafness. But it does give you promontory stimulation to see that the nerve is intact. So what are some other ways that we can kind of identify whether or not a nerve is intact? Let's go through some intraoperative monitoring techniques. So Dr. Talishi and the group at Miami has reported on otoacoustic emissions. We don't find these particularly helpful, mostly because they're lost when people have hearing loss, but also, from a translab approach, you're going to lose it. It is a near field measurement, meaning we're just really monitoring the cochlea and not the entirety of the cochlear nerve and auditory pathway, which is, of course, critical when dealing with a tumor on the nerve of hearing. Electrocochleography, this is kind of near and dear to us at WashU. We find that this is actually a very meaningful way to measure overall cochlear function and has some interesting potential future applications for differentiating nerve-related hearing loss versus an intracochlear source of hearing loss, but it's still a near-field measurement, so it's not going to help us with more proximal parts of the cochlear nerve. Each of the cochlear implants has their own proprietary neural telemetry, which is again a near field measurement, and we find that electrocochleography provides us with more information. An interesting report from the Mayo group was electrical stapedial reflex testing. So this is easy to perform. You literally just stimulate within the cochlea and see if the stapedius muscle fires and if the stapes moves. So it does interrogate the entire reflex arc. Not sure if it will give us any predictive data on outcomes, and based on their setup and the current devices available, this does require a cochlear implant to stimulate that reflex, at least in the translabyrinthine approach. Dr. Welling mentioned this, and Dr. Cuevas reported on the benefits of cochlear nerve action potential, which is a direct recording from the proximal cochlear nerve. Getting the actual paddle or signal from the proximal cochlear nerve can be challenging. The device used by Dr. Cueva is no longer readily available. So when we do this, and mostly in hearing preservation cases, we kind of bend a subdermal electrode needle, but this has a really strong signal if you can get it to work, and it is a real-time measurement of the health of that nerve. Unfortunately, from what I will discuss in our clinical trial is that when you are stimulating within the cochlea from an electrical source, this just is not feasible. There's way too much artifact, so this is not possible. And if people want to learn more about the ins and outs of the various intraoperative cochlear nerve monitoring techniques, I'll direct you to this clinic's otolaryngology article that goes through them in more depth. So auditory brainstem response in our hearing preservation cases, this is the gold standard. We give, a sound source in the ear, and through subdermal electrodes on the scalp, we're recording activity as it progresses along the brainstem and midbrain and has characteristic waves. ABR is not feasible when the patient has already lost hearing, and of course, during a translabyrinthine approach, you're violating the inner ear, and so this is not going to help. So one of our basic questions was, what is the utility of electrically evoked ABR or EABR? So again, Dr. Welling kind of set the stage. NF2 is such a challenging disease, and the health of those cochlear nerves is so important. So we did kind of a feasibility trial, just opening up a cochlear implant in the to facilitate EABR recordings, and we saw that we were able to get a signal, and it was able to provide some predictive data. But this is not a practical approach for spontaneous tumors to be opening up an expensive cochlear implant. So is there a device that's more practical to run EABR? And that's where our clinical trial comes in. So the main objective of our clinical trial was just to demonstrate feasibility of cochlear nerve monitoring through a novel test electrode. And then, of course, bigger picture, we're curious, is this EABR going to predict CIA outcomes? And then, start to discuss, hey, is a CI in a vestibular schwannoma patient really going to, change the needle on the quality of life? So our clinical trial protocol was pretty vague, mostly adults, small to medium size tumors, which could be sporadic or NF2. We wanted these patients to have no serviceable hearing because we were offering them a translabyrinthine surgery, no prior tumor treatments, and realistic expectations. And here was the protocol. I just want to point out that, during the surgery, EABR was not our deciding factor on whether or not to go ahead and place the cochlear implant. That was still based on the surgeon's identification of the cochlear nerve being intact, as we felt that was the gold standard, at least currently. And then we did a number of quality of life surveys. So the setup, I think, is pretty easy to understand for this auditory nerve test system. The EABR is really run the same way as far as the scalp electrodes go. We actually don't need a sound probe in this case. That'll come within the cochlea. And so when we do the translabyrinthine approach, before we open up the posterior fossa dura, we insert this test electrode, which is like a mini cochlear implant. And then as we're dissecting the tumor, we're looking at the EABR signal, just like we would a regular ABR in a hearing preservation case. So this is the auditory nerve test electrode. It has 3 intracochlear contacts and a 4th contact, which is an extracochlear ground. Again, like a disposable mini cochlear implant. It does not have, the disposable part does not have the inner workings of the internal receiver stimulator unit, and so theoretically this would reduce cost. There's also a disposable connector cable, and then there's a stimulator box which runs the device, and this is a reusable platform. So what does the EABR with the auditory nerve test system look like? So here's kind of one of the manufacturer's schematics of what they hope the EABR looks like. And I have an arrow on wave 5 because that's really what we're going to be monitoring. But in reality, this pretty tracing is not what we see. This was taken from our case series with NF2 and using a cochlear implant. And you can identify wave 5s. It's hard to see this in one snapshot, but as the audiologists are continually running the 1,000 to 2,000 sweeps, you find reproducibility of the wave 5. Also, this figure is a little disorienting because the scale is larger, so the wave 5 does look quite small, but this was reproducible. It's important to note that there were other things that we saw. So there's, in our experience, wave 2, wave 3, those are not viable because of all the electrical artifact from the stimulation. And then in the case of NF2, where those patients are obviously complicated and perhaps we're having to stimulate at a higher level, you get some non-auditory stimulation. So this is a big, muscle firing from facial nerve stimulation. So there's a lot of artifact to manage with the EABR approach. To go back to our clinical trial on the auditory nerve test system, this is what kind of one case looks like. So this is a left ear translabyrinthine approach. Okay, the test electrode goes through the facial recess into the round window. It's draped anteriorly, so out of the surgeon's field. And then before we open up that posterior fossa dura, we're stimulating at different current units, and we're getting some baseline recordings. So let's jump into one of our case subjects. To me, this is the ideal patient, 21 years old, NF2, that left ear, relatively small tumor, and no hearing. So the real possibility for a major intervention. NF2 is complicated, as we just learned about, and so this patient actually had 3 different tumors. There was a tumor within the vestibule, there's a distinct inferior nerve tumor, and you see a cleavage plane with the superior nerve tumor. So as we're moving along, those vestibular nerves are resected. You have clear identification of the cochlear and facial nerves respectively, and we're monitoring the nerve with the EABR recordings. And this is going nice and smooth. At the end, the tumor is out. We believe the cochlear nerve is intact. We swap out the test electrode for a cochlear implant, and the wave 5 is still there. Lots of high fives in the OR that day. Most importantly, how did the patient do? Well, they did okay. If you look at their baseline, something was wrong with this patient's nerve or cochlea, right? So they're coming in with a diseased ear. And did they get sound? Certainly. Did they get, CNC words and open set speech? Probably debatable with those numbers. And in general, the patient, so the outcomes were a little more muted compared to what we would expect based on the preservation of a wave 5 EABR. Did the patient like it? So again, we did lots of patient reported outcome measures, and despite giving this patient some hearing in that ear, he didn't love it. He still has normal hearing in the other ear, and so comparing the 20 whatever percent CNC scores to 100% on the other side, it was really hard for him to use it. So again, lots of high fives in the OR, but did it translate into this patient, having a big bump in his quality of life? And unfortunately, the answer was no. Let's look at another subject. We thought this one was interesting because, relatively small tumor, had non-serviceable hearing, but had some baseline word scores, as I'll show. And when we first ran the baseline numbers, there actually wasn't any EABR present. Okay, so we continued on with the dissection, continued running, and ultimately, when the was debulked and removed, a wave 5 became present. So not sure what that says about the source of the hearing loss, and whether this was a nerve related thing or pressure related thing, but I think there are interesting things to explore with this type of information. How did this patient do? From their baseline, he did not get back to his baseline CNC scores. Did he have sound recognition? Did he have, some use of the device? Yes, he still uses it daily. Did have improvement with sound localization. From a hearing subdomain, this patient did have a significant improvement despite somewhat kind of muted responses with the device. So this just highlights kind of some of the patient variability when it comes to their quality of life. So basic things as far as our objective number 1 EABR with this auditory nerve test system is, yes, it's feasible. We didn't have any intraoperative complications or facial nerve problems from this type of stimulation. We're really stimulating it like we would a cochlear implant, and so that all makes sense. It's relatively easy to place, and potentially this is commercially available in Europe. It is not commercially available in the United States. We were using it on an investigator-initiated exemption, but theoretically it could be more cost-effective than opening up a cochlear implant. Reliability of these recordings, I do think, warrants some discussion. There's a lot of artifact with this form of stimulation, and so managing that artifact both in your OR environment as well as what software you're using to capture the ABR is important. And then, unfortunately, we did not find the cochlear nerve action potential to be doable in this approach. What about predicting CI outcomes? So we have a small cohort of only 10 patients, so can't hang your hat on this too much. But as we potentially pool our data with other European centers and other people using it, maybe we can answer it. Let's look at, again, a few more cases. This is subject number 4. Right-sided tumor, again, the intraoperative setup. I showed this just because we were still trying the CNAP at that time, and you can imagine how hard it is to both dissect tumor as well as deal with the pulsating CSF while keeping kind of a non-specific electrode at the root entry zone of the cochlear nerve. You can also hide the electrode a little bit better or keep it draped anteriorly with a little bone wax up in the zygomatic root region. So this was one of our all-stars. She did really well. Interestingly, her baseline hearing was a little bit better than those other 2 subjects. So maybe the nerve and or the cochlea was not diseased coming into the surgery. At her 6-month testing, her CNC scores were as high as 64%. Now, they dropped off over time, and our audiology group has a lot of experience with single-sided deafness. They do see this in their SSD patients. In the beginning, there's a lot of hands-on rehabilitation and motivation to use the devices, and as they maybe become more lackadaisical in their use, then sometimes these numbers drop off. Of course, this is a unique patient population, and we need to consider, could there be fibrotic changes within the cochlea, vascular changes with the nerve of hearing. I think these patients are going to be more dynamic and need to be followed on a longer basis. This patient, again, had great sound localization, and overall the quality of life metrics really were improved in her. So she's kind of one of our poster childs of the potential benefits, although reproducibility of it is challenging. Speaking of, let's go to subject 1. So our first case, again, showing some intraoperative pictures. It was very smooth, small tumor came out, cochlear nerve was intact. We had great intraoperative recordings with preservation of wave 5. How did the patient do? Discharged uneventfully on wave 3. Day 3. On post-op day 11, she had a delayed facial paralysis. She fully recovered from this, was treated with steroids and antivirals, but lo and behold, at her CI activation, she did not have any sound awareness, which was clearly disappointing for all involved, given what we found intraoperatively. So again, these are dynamic patients, and there are going to be things that change even outside of the operating room. So her numbers from speech perception were obviously poor. Interestingly, as Dr. Adunco alluded to, some people just get relief from having their tumor treated. So her quality of life things actually improved despite us not providing much benefit from a hearing standpoint. And, again, it's a small cohort of patients. And so don't want to put too much weight in these outcomes. I do think it's interesting that our numbers don't live up to some of the numbers reported from other centers or what is in the literature. But I think this is an honest assessment of the challenges in this space and with cochlear implants with tumor resections. Leave it to a formal clinical trial to have some variation. So we had 2 surprise kind of protocol deviations in which it actually wasn't a vestibular schwannoma. We had an IAC hemangioma and a meningioma. I can guarantee you these scans looked like vestibular schwannomas. But lo and behold, there were some different pathologies. Of course, this approach can be used for those different pathologies. Not sure exactly what to say about it, but the meningioma patient did really well and had a good wave 5. The IAC hemangioma, the wave 5 had a delayed latency and that never looked healthy. So perhaps there was some predictive element there. And so the status of the trial, we're no longer actively implanting. We've actually we've completed the data on the 9 patients, and we're in the final steps of analysis. We had 1 patient withdraw due to a non-related injury and non-compliance. And as I said, overall our numbers are a little bit less than we had hoped for, but I think this is an honest look at the challenges of this space. And another thing that I want to bring up is, whenever we are, trying to do these operations and serve the best interest of our patients, there's going to be some subjectivity to, when do you cut, the vestibular portions of the nerves to preserve the cochlear nerve. And so we need to be mindful that this approach may lead to some residual tumors and you need to monitor them. In general, with a cochlear implant, you can see the ipsilateral IAC and CPA. I think in this approach, the magnet is actually a little more posterior and superior, so the artifact is reduced, but there's a lot of variation in the artifact. And what is not discussed in the literature much is, let's say there is regrowth, or in the NF2 patient situation, he developed a facial nerve tumor down the road and needed Gamma knife for it. And so that magnet needs to come out for the Gamma knife treatment planning. And then quality of life. And just to summarize, this is going to be very patient dependent. So we want to be careful with what expectations you set. We know that when people have hearing loss, it's a major reason for them joining some of the vestibular schwannoma support groups. Understandably, there's anxiety about losing hearing in the contralateral ear. So a cochlear implant, has potential benefit there. And then it's going to be critical in those NF2 patients to give them any sound. But it's really difficult to manage patients' expectations as we try to restore function in a disease that otherwise we were just holding on to function as long as possible. So to conclude, our ANTS, the auditory nerve test system, can give us information about the health of the auditory or cochlear nerve, but I think we have a lot to learn about reliability of this and the predictive value of it. And I would say there's cautious optimism for CIs with vestibular schwannoma, but there are a lot of questions when it relates to delivery. We like the idea of a simultaneous implant with translab resection, but questions of baseline health of the auditory nerve, can we improve EABR feedback? And I'll just throw out there that, the data on things like CIs after stereotactic radiation or in those older patients with stable tumors also looks quite promising, although the numbers are very small. And so I'll bypass those final slides, which show those non-surgical approaches, but the data is out there. And just want to thank again everyone for including me in this panel and the team that I have at WashU.
Thank you, Dr. Wick. That was a great talk. And I love how we're kind of thinking of giving things back to people instead of just preservation. And I think trials like that's why are so crucial and innovative in that sense. So I really enjoyed your talk. And then next, I would like to introduce our final speaker, Dr. Shi. Dr. Shi is professor of radiation oncology at Harvard Medical School, and she's the medical director of MGH Proton Therapy Center and director of CNS and eye service. She is an expert clinical trialist and a clinician, and her clinical expertise lies in the management of CNS tumors, including vestibular schwannoma. And it's my great pleasure to invite you to this conference.
Thank you very much for that kind introduction and for having me here to close out this year's symposium. I trust you guys can see my slides, okay?
Yes.
Yep, we're great.
Great, perfect, thank you. Oops. All right, I have no relevant disclosures. And what I'm going to try to do today is complement what you've already heard throughout the morning about radiation therapy. Dr. Choi really covered the crux of radiation therapy, what it is, what we think about it, and how we use it. And I think the bottom, I'll hit the punchline and I'll kind of go backwards, is that SRS really, if you're applying radiation, SRS, I think, is uniformly the most common, efficacious, and safe form of radiation treatment. But that being said, what I want to focus on, well, there's other things we do with radiation. Other speakers have touched on this. There's fractionated radiation therapy. We like to deliver it with stereotactic technique, meaning just a little bit higher precision, so use a lower margin around the area that you want to treat, less normal tissue exposure. There's factors, and touch on some of the factors impacting radiation response, which is a little bit into what radiation oncologists are thinking about as you go into treating patients, and also how they counsel patients what to expect. I'll touch a little bit on proton therapy, since that's a thing here at MGH, although not so much for vestibular schwannomas anymore, but to take you through that history. And then just we've already heard a little bit about NF2 patients, how these forms of radiation may have a role in that population. So starting with the rationale for fractionated radiation therapy, why will we do it? What's involved? It's daily radiation, Monday through Friday, 5 days a week, usually in order of 25 to 30 treatments. As compared to a single treatment for stereotactic radiosurgery, it seems highly inconvenient. It totally is. So when would we actually employ it? It's really when we feel that perhaps single fraction SRS is unsafe. And the most common indications is either because the tumor is so large, the patient's symptomatic, you're concerned about reactive swelling and edema, or perhaps the patient has had radiation exposure before and you're worried about the cumulative radiation dose. In regards to, there's no great prospective data, but in regards to retrospective series that are out there, taking you through, these are many of the studies in the first decade of the century, 1999 through 2007. These are mostly small, single institutional series, up to like 20 to 100-ish patients. The standard fractionation, 45 to 54 gray at 1.8 group of fraction was the most common. The follow-up is mostly in the 3 to 5 year period, and the local control was really good, 94 to 100%. Toxicities in terms of cranial 5, 7 was relatively low, was preservation is listed here, high 90s to 100%. Hearing preservation was very mixed all across the board. There was some preservation, but not no uniformity in how we characterize how much. In a more contemporary series, as shown here, and these are studies in the last decade, mostly in the last decade. I divided out, you can see in the top part kind of in the light green, are hypofractionation. So this has become a thing across the board in other diseases like prostate, breast cancer, and so forth. Basically, the idea is our imaging is better. We can see things better. We can target things better. There's less excess radiation going to the normal tissues around whatever we're treating. How about we just give a higher dose each day and just shorten the course, make it more convenient? These are mostly 5 fraction or 1 week course of treatment. Some of them are 3 fractions also. And they're also a more contemporary series now, most common dose frame of 50.4 to 54 gray. And what you see again, these are still relatively short follow-ups, and you think about this as a benign tumor, and hopefully these patients are living for decades, not just 3 to 5 or 7 years. Local control, again, is still very high, 95 to 100% in most series, and the toxicities are similar, actually. Hearing preservation in this gray zone, 50-60%, and then trigeminal facial nerve dysfunction, relatively low single digits. What was also done recently was comparison. This again is all retrospective, but 4 different institutions put forth that they actually treat them a variety of different ways, and we do too at Mass General, and say, well, we do a lot of SRS, but sometimes we hypofractionate, or sometimes we do just standard, normal, traditional, conventional fractionation. And what I tried to show here is the SRS are in the light blues, the hypofractionated are in the lavender, and the regular fractionations are just left in white. But the 4 different institutions across the board, the follow-ups are still, same idea of 2 to 5, 7 years. The doses are standard, as we've heard this morning, and the local control remains the same on the order of 95-ish%, if not higher. And there's not much in terms of toxicity, but I think most people would, practitioners would agree that there really is not a difference. So just to provide you a case of what does the fractionated stereotactic radiation therapy look like, this is a patient of mine, 52-year-old male with a right vestibular schwannoma. He presented with tingling, numbness of the right side cheek, just lateral to his nose. So we know it's on the larger side, right away. And he's got a moderately 4.5 centimeter tumor that you see here, and it's cystic. So we sent him off to the surgeon. This is a T1 axial, and this is actually a coronal T2. See, it's cystic component of the tumor. Goes to surgery, and it's subtotal, so there's still a bit there. So we just decided to watch him. And then unfortunately, 2 years later, it progresses. You can see here it's gotten bigger again. He didn't want to go for further surgery, so we acquiesced and treated him with fraction and radiation therapy. I treated him to 49.3 gray at 1.7 gray per fraction. I was concerned about it being cystic, and these larger tumors, as we've heard multiple times, are more prone to being reactive and swelling and causing symptoms. So this is his pre-radiation scan again. 6 months later, you can see this consolidation of the cysts, which is not unusual. We see thinning with an enhancement. And I think it's really important for radiation oncologists to know like how these tumors react to radiation, because oftentimes they'll look at this and be like, oh, it's getting bigger because the absolute size is larger, and they send them off to surgery to have it taken out. But if you hold tight and the patient's not symptomatic, I don't remember him being symptomatic, a year later, then you see that collapse. 6 months later, I should say, it's a year post-radiation, and he's now 2 years out. I just saw him last week, and you can see that his scan looks great, and he's doing well, although no hearing on that side. What are some of the factors impacting radiation response? The tumor control itself does not seem to be impacted by how we divide up the radiation, whether you give it a single fraction, you hypofractionate 3 fractions, 5 fractions, or you do standard fractionation. We don't have any prospective randomized data, but if we look at retrospective data, such as this systematic review that pulled out 5 studies that actually were the investigators did both SRS and fractional radiation, we see there's essentially no difference. This is for tumor control. And in your own series from the University of Wisconsin, this is a great article also that looked at local control. Comparing between these different fractionation schemes, they're essentially not different. So the reason that we choose one fractionation scheme over another is it's so multifactorial, right? So each one of these patients needs a unique plan, and by the time you decide on radiation, there's factors that drive you away from SRS is usually what it is, because we start with SRS is what we prefer, and if there's a reason we should consider something gentler, we'll go that way. But we can essentially adjust the dose and fractionation to maintain the same local control. With regards to hearing preservation, which of course is paramount to the patient's concern, we also don't find that there's a difference. In some of those early retrospective series, and I think it was done, those studies were done in an era where we didn't have the localization, the radiation planning techniques that we do now. A lot of investigators really fell back to doing fractionated radiation. They also just didn't have SRS systems in their institutions, and they felt like there was a sense that like, oh, there was better hearing preservation with fractionation. That was definitely one of the dogmas in radiation therapy, I think 20 plus years ago. But increasingly, as we're having more data, we are not seeing that to be true. And this again is the same Wisconsin data looking at serviceable hearing. Really no difference across the different schemes of fractionation. This is one of the more recent studies from Vanderbilt that suggests, well, maybe there is a little value to moving from single fraction in terms of the comparison hearing from baseline to their last follow-up of a few years, I don't recall offhand, but like 3 fractions versus 5 fractions, perhaps was slightly more hearing sparing. So there is some of this data that kind mixes in a milieu and confuses it a little bit. In general principles in radiation therapy, we do say, well, if you're not sure about safety, you divide up the dose more, and it's always a little bit safer to the normal tissues. But again, with these tumors, generally they're so small, and if you can really localize the dose of the tumor, stay off the brain, brainstem, and surrounding normal tissues, we don't really see a difference. And ultimately what we see, this is a great study from Johns Hopkins. I like to study because they dared to go lower, 46.8 gray. Most of us don't go quite that low when you fraction in. I don't either, because you see one failure or two failures and then you get risk adverse, right? So I usually do 50.4. But what they found is, and I think this is what we see in other retrospective series, or certainly subjectively what's experienced, that if you're going to choose fraction radiation, those people who have baseline better hearing, Gardner and Robertson 1, 2, tend to have the ones will do better than the twos in terms of hearing preservation, and also dose. We see this with the single fraction radiosurgery where we try to stay below 4 gray. Same thing as fractionation. If you stay below 40 gray, you have a better chance of hearing preservation, but that's not always our choice, so to speak, right? If the tumor is right up against the cochlea, we tend to prioritize making sure we treat the tumor. Not sure if that's necessarily always the right thing to do, but I think that's still the practice for the time being. We're also aware that after radiation, there is this reactive effect. It does seem to track with larger tumors. This is a study, this has been done a few times in other retrospective series as well, and they've shown that the growth rate before radiation predicts for the response after radiation. And this is 65 patients, roughly half-half, single fraction versus standard fractionation over 5 to 6 weeks. And what you see that those patients that are not growing so much prior to radiation treatment, meaning on x-axis, lower growth rate, tend to shrink in red after radiation treatment. And those tumors that have a faster growth rate will tend to actually have that expansal that you see on the green here, and as represented by the image here. And that, again, is just an important thing that patients need to be counseled by, because sometimes they become symptomatic, and not to worry, because nowadays they have access to their radiology reports and images before they even see us. So they're like, wow, it got bigger, the tumor is growing. Is to understand that this can in fact be a normal radiation response. And in most circumstances, you can wait it out and it will subside. To touch a little bit on proton radiation. So this is my physics slide. It's like, why protons at all? This is what we call a depth dose curve. The y-axis is radiation dose. The x-axis is depth into tissue. Ideally, what we want to do is just deliver a fixed amount of radiation at a certain depth, and that's it. Nothing upstream, nothing downstream to it. The reality doesn't look like that at all. Photons, it doesn't matter if it's cobalt-60 or linear accelerator created of one kind or another, has a depth dose curve that looks sort of like this. There's a quick buildup of dose. There's a peak that's probably in the skull because it's just a few millimeters deep, and then it trails off. How the slope of this trail off is a little bit higher as energy goes up. But essentially your highest dose is usually upstream to where you want to target, and then there's a bit of dose downstream. The proton dose profile looks like this. So there's still a dose upstream, but it's a bit less than X-rays, and then it drops off and there's almost nothing after it. So it would seem that protons has less dose to normal tissues. The highest dose in the targets, isn't that a great thing? We should develop this. In fact, Lars Laxell was the first to really dabble into protons for radiosurgery, and decided after some point that it was too cumbersome and complicated, and thought photons were a better way to go, and he was correct. But at least at MGH, how do we pick patients for protons? Well, before we had photon, which is that we have a LINAC-based system for radiosurgery, there was a time when all we had was protons in the 60s, 70s, 80s. We were doing a bit of proton radiosurgery at that time. There was no photon system at the hospital. But with the advent and advancements of photon SRS system, we've really scaled back who we offer protons to. And we really narrowed it down to this set of population of really children, young adults, people who are trying to reduce that normal tissue radiation exposure. In other circumstances, they're similar to that. So if not that patient population, people who've already been treated with radiation before, or people who may need a future reason for radiation exposure, such as tumor syndrome patients, NF2 patients. There's multiple it's usually meningiomas, not the schwannomas, that are rationale for the radiation treatment, but you see them, they're growing. It's just a matter of time that they may come back. Protons may afford a little bit more opportunity for safer retreatment in the future. An example of our proton SRS case, here's a typical left-sided schwannoma, and 12 gray, we use the same doses that we do on the photons. These are what our typical plans look like. There's no radiation on the contralateral brain, but there's actually a little bit of low dose radiation on its lateral side. And then a year later, you get your typical response of being a little bit less enhancing for a little bit of period of time, and then some shrinkage a few years later. Very similar to what we see, actually the same to what we see on photons. One of the limitations of protons or radiation in general, as you can see here, is the radiation is not just going to the tumor. It is clearly going to a little bit of the vestibule and the cochlea. And for that reason, when we look at our own retrospective data on proton SRS, this is pre-SRS, right before treatment, mean speech discrimination score graphed with a pure turn average. So good hearing is top left, no hearing is bottom right. You see a mix of some hearing in these patients. And then within the first year after radiation, really patients even notice it like a month, 2 months, 3 months. It's pretty rapid, actually. They start losing hearing, and 1+ year out, most of these folks have lost some degree of hearing. So this is not a hearing preservation strategy. And the reason why that is, it comes down to the dosimetry. So the proton beam stops. This is a dosimetric study. It is protons on the left, a 5 millimeter MLCs and a 2.5 millimeter MLC. So these are different photon SRSs, linear accelerator based SRS. It doesn't have compare gamma knife because I don't have that at my institution. So I just use what we have here. So the best protons on the left with the best linear accelerator on the right, which you can see right away is the advantage of protons is this sparing of this low dose blue radiation. But that low dose radiation is clinically probably fairly insignificant in anybody, 50 and older, 40 and older. And the benefit of photons, and it will be even more so with a gamma knife, which has a sharper dose fall off than linear accelerator based system, is that you don't have as much high dose in the normal tissues immediately around your target. So, and that's also a really hard concept to explain to patients because there's so much media out there that we frequently have patients coming for protons that in fact, their intermediate to higher doses is higher with protons. And the advantage of less low dose scatter is perhaps really limited to a very small subset of patients. So who again do we treat? Large tumors, prior radiation exposure, patients who we think have an increased radiation sensitivity, might need future radiation, and then sure, super young people, pediatrics, and maybe some younger adults like in their 20s or 30s. And they tend to overlap. Who gets a vestibular schwannoma in their 20s? Oftentimes a tumor syndrome patient. The secondary tumor risk that concerns lots of patients and drives them to come seeking protons is based on this. This is actually a modeling study where we took a bunch of, there were actually meningiomas, but another benign tumor, different sizes, locations in the head actually. But the concept is still here the same. And we modeled out the secondary tumor risk with photons and protons based on tumor size. And the bottom line is with photons, it's always going to be roughly twice as much as compared to protons because that's twice as much scatter going to the head, radiation. And as your tumor volume increases, the absolute benefit is far greater. So a patient may come to you and say like, oh, but I need protons because it's twice as safe, right? But the reality is the target volume is going to be practically on the y-axis, right? The absolute benefit is actually quite small. And so that's also a point we often counsel on. What's a typical proton patient look like here? This is a 73-year-old woman who I treated who had progressive left-sided hearing loss, tinnitus, had some symptoms of mild imbalance. She was treated with 50.4 gray of protons. This is her treatment plan. So the advantage, if there is one, is that there's no dose to the contralateral brain, but there's still going to be dose fall off at ipsilateral and around the tumor and the normal structures there. So this again is our pre-radiation scan. A year later, as we've already heard, but this is a great point for a radiation oncologist because if they're hopefully following their patients is that you do get this modeled change. You see it even at 6 months. I actually stopped doing 6-month scans because I found all it did was create stress for patients, and basically 100% of the time wasn't representative of anything other than radiation treatment side effect. So the first scan I do post treatment is 1 year out. It's a classic treatment response. 2 years out, you can see like it starts imploding. collapsing on itself. And just saw this patient recently, also 3 years out, doing well clinically, and no hearing on the ipsilateral side, but otherwise doing quite well. When we actually look at our series and say, okay, so there is some proton experience, how did your patients actually do? 85 patients with this fractionated radiation, 50 to 54 gray. Local control, again, it's as good as any other series, 96%. However, we don't really improve on hearing in terms of hearing preservation, and there's still this single digit risk of other common side effects. Again, one of these sort of same scatter plots for hearing, this is fractional radiation. Most patients who started had good to intermediately useful hearing. And within the first year, we see a dramatic drop in hearing, and that just continues long term. We do have a prospective study, so that was all retrospective. So somewhere along the line, we're like, we should follow this prospectively so we can see with a little bit more granularity. We did a phase 2 study. This is the first 20 or 30 patients being reported. We started at 54 and then decreased our dose shortly after opening the trial as our new standard. And just because the data is so compelling everywhere around that we did not need to go higher than 50 gray. This was with a median follow-up of 4 years. Our local control was 100%. And what we see here is the serviceable hearing drops by half within the first year. And then a few patients are out to 3 years at this point. And again, when we look at other metrics, PTA, word recognition scores, we see this the disappointing decrease in hearing that comes with this. So with protons, we do achieve similar high local control, but there is a high risk still of hearing loss. We did find, that's not shown here, but in our analysis that also similar to one of the retrospective other studies that I showed you, that lower dose to the cochlea is meaningful for hearing preservation. And that ultimately doesn't matter what modality you use, it's just staying off the cochlea is probably the right thing. And that's also, the discussion of like treating early. You treat earlier, the tumor's smaller, you have a better chance of minimizing the dose to the cochlea. And then lastly, so, NF2 we've touched on a few times, but oftentimes they come up in a context of should we fractionate, should we use protons, because we're looking for a radiation modality that's a little bit softer or gentler, and so you either fractionate it or maybe protons a little bit more sparing. Those are kind of the rationale how these patients get referred to us. There are limited data out there on NF2 and fractionated radiation. The little that's out there suggests that it doesn't work as well as SRS. Maybe that's because they're larger tumors. That's why they get fractionated. In this series from Brazil of 54 patients, those patients, and it was just a retrospective series, so not randomized. When you looked at larger tumors, who got 2 centimeters, the proportion of 2 centimeter or larger tumors, SRS versus fraction radiation, 48% of the SRS cases were greater than 2 centimeters, 64% of the fractionated. So it was just more larger tumors that received fractionation. The tumor control, however, was notably different, 90% for SRS, 2/3, 67% essentially for the fractionated. And that is the sense, actually, I would say that latter number is really the sense that most people who are radiate these tumors, just a sense that NF2 tumors are a little bit more resistant to sporadic ones. The mean progression-free survival here was significantly different. In our own experience, we had 8 patients, 5 that received fractionated protons, and 3, and this is just proton subset only, 3 that received proton SRS, half at diagnosis, half at recurrence. Median follow-up was 71 months. 3/4 of them, 6 out of 8 of them, remained controlled. When we looked at the hearing function, 6 were deaf at pre-radiation, so of course that didn't change. 1 was near deaf, became deaf, and 1 was serviceable hearing, also became deaf. So no one preserved hearing of the 2 of this small cohort. And then when we look at other symptoms, 6 out of 8 had additional clinical symptoms. It was very similar to what you would expect, I think, in any other series with photon-based treatment, is that you do get facial numbness, weakness that are transient. Typically, the tinnitus not so transient, and the balance a little bit more variable. Just as some example of cases, so these were 3 of the NF2 cases up here. Patient A, pre-radiation. The left-sided one was being treated because that was growing a year post-radiation, looking stable. Last follow-up 5 years out, looking great, stable. Patient B had a right-sided tumor that was irradiated, and a year later, it was slightly expansile, and I don't recall, but the patient was symptomatic such that our neuro-oncologist started bevacizumab, and now a few years later has stabilized. You can see the tumor actually responded quite well to the bevacizumab. And as we've also heard earlier this morning, this also happens. Patient C, where we're treating this left-sided tumor, great response 1 year out, and then humblingly, just beyond 7 years, had clear progression. So these patients really do need to be followed. We get lulled into this comfort zone at 5 years, like, oh, everything looks great, it's small. But actually, I never let these patients go completely. I always follow. I'll stretch it out eventually to once every 5 years, but I feel like you just never know. And so we should follow these patients long term. So in summary, radiation is an excellent option, I believe, for definitive treatment of vestibular schwannomas. It is a multidisciplinary discussion. Like the focus of my talk is really, if we're going to get radiation, what's the deal with fractionated radiation and other things of that nature. But in fact, each one of these patients sees, sees a surgeon, sees a radiation oncologist, and we confer, and there's usually great alignment, thankfully, on the plan. If they do get radiation, we still support single fraction SRS, that we've heard earlier, as the most convenient equivalent local control and no decrease in toxicity. But there is a space for the minority of patient, which is probably, it's less than 10% of our patients that get fractionated radiation. Again, larger tumors, having some predisposition that makes us concerned about doing single fraction SRS, whether it's a tumor syndrome, which is not, that's just only sometimes, re-irradiation often. And then with protons, we even have a smaller subset. I probably treat 1 or 2 patients a year at this time with protons, and usually it's an N of 2, because where else do we see it in kids, right? Tumor syndromes or in the setting of re-irradiation. And with that, thank you all for your time. We also, like everyone else who's spoken this morning, have the luxury of working with an amazing multidisciplinary team, not just other radiation oncologists and the radiation team in medical physics and dosimetry, but really the greater neurology and surgical teams. I love Lexi's talk. I feel like vestibular therapy is everybody's friend for this patient population. They all do much better if they can embrace it. And thank everyone for their time.
Wonderful. Dr. Shi, thank you so much for that great talk. I really appreciated your in-depth dive on fractionated therapies. I feel like sometimes that's a forgotten tool. I think it's difficult for clinicians, especially radiation oncologists, to understand the appropriate application of that treatment technique as opposed to single fraction. So it was refreshing to see some of that data. Now, the majority of your slides and the data that were shown were for much longer courses of radiation than what I was familiar with. Can you comment on your selection of those longer, I'm going to call it more traditional courses of external beam radiation therapy over 28 to 33 fractions, as opposed to where I feel like all of our field is heading to with applications of 3 to 5 fractions for vestibular schwannoma? Would you be able to provide some insight into that?
Yeah, I would say, most of my experience is still traditional fractionation, which is doing it 28 fractions to 50.4. I'm not adverse to doing shorter. It's just that you don't want to guinea pig your patients when you don't have the experience yourself, personal experience. So the few that I've done, and I've done like 5 gray times 5 or 4 gray times 5, 4.5 gray times 5, have been in more advanced age patients where you just feel like, gosh, I just can't make this person come in for 6 weeks for something that there's some data on. It's retrospective, but it's limited. But just rationally thinking through, like, we can treat this in a week. And if there's something to more advanced age patients, it doesn't even seem to matter what you're irradiating. But after 3 weeks, fatigue and just like this, their capacity, their stamina to continuous radiation drops dramatically. So, the field captures this in treating things like glioblastoma and so forth, where we hypofraction for 3 weeks. There is they can tolerate 3 weeks. Going beyond that is less, but 1 week's even better. And so I've done it. I do it for older patients who, even younger ones who are like, I can only be here for a week, I'm from out of town. But I would say generally for younger patients, if there's a rationale for me even fractionating at all, because it's a larger tumor, I usually still fall back on the 5.5 weeks just from experience. And maybe that will change as time, as you know, our global experience with other investigators and reporting their data increases.
Perfect. I'd like to ask our the second half of our panelist group to rejoin on camera as well. And the invitation still stands for the other participants to send questions to our panelists through the chat box. I did have a question, and perhaps best answered by Drs. Welling and Wick. You know, every time, at least in our clinic, in our experience, when we see a patient with bilateral vestibular schwannoma, you know, pathognomonic for neurofibromatosis, you know, with varied states of hearing on either side, I always feel like we're recreating the wheel with regard to, you know, application of which one do we treat, which one do we observe, which one do we implant, which one do we don't. And I'm just curious if you could provide some insight on workflows and algorithms that you guys use when trying to decide what is the best approach for the patient. And please feel free to draw on your own clinical examples if you got them.
Cameron, do you want to go first? I don't know where my picture went, but I'm here.
Sure. Well, yeah, I don't think there's, you know, there's no cookie cutter answer, you know, for that. So they all do require individual look and individual ear assessments, and and of course we care about the hearing and the ears, but those are complex patients and what's going on with their spine and other issues, and you know, other cranial nerves. And so yeah, it's a very individualized care, and sometimes you do have to just work through all the options and make sure all team members are on board. And certainly I'll defer to Dr. Welling with his experience.
There's my video. Can you hear me now?
We sure can.
Okay. Yeah, I agree with what you said. I think that it's individualized. I don't think I'm very good at saving hearing in tumors that are more than about 1.5 centimeters. And so from a surgical consideration, if it's 1.5 centimeters or less, and I prefer much less, that would be 2 or 3 millimeters. I think hearing preservation is a consideration. I usually go after the smaller tumor first, and I go after the one that has the best auditory brainstem response. I prefer one that is away from the cochlea, that's in the middle part of the internal auditory canal, has a fundal cap of fluid, and I think that if it's on the superior vestibular nerve, we're much less likely to cause harm to the cochlear nerve than if it's on the inferior vestibular nerve. So all of those things push me in that direction. If I get a 2 millimeter tumor on the superior vestibular nerve in the middle of the internal auditory canal, I take it out right away, especially if they're ABRs wrong. But I think there comes a point where I have to say, you know, I'm not likely to save the hearing on this hearing that's larger than 1.5 centimeters. And also depending on location and so forth, I think that I may try to observe those patients when they start to lose hearing. We put them on bevacizumab, see if we can get some of the hearing back, try to prevent the tumor from growing. When they get large, we take them out or send them to Dr. Sheila consult in terms of what we should do with the patients. She's gotten me out of a few tight scrapes with tough patients, so I appreciate. I do think it's a multidisciplinary team, and I think that one of the really nice advantages in working in those kind of teams, we just have a lot of people with a lot of good common sense that have reasonable expectations, and I think in the over 10 years I've been here, I don't think I've ever disagreed with this opinion that Helen's had on how we should manage a patient, and she's been, you know, it's just really nice to have that kind of working relationship. But it makes it very if we could have a team meeting and have everybody agree on what the plan ought to be, and we do have monthly team meetings about these things, you know, it helps the patients, especially with tough NF2 decisions. When the team can't agree, it makes it really hard. Like that first case I presented, where the 2-year-old boy had these multiple tumors, and I just knew he was going to need them out, and I wanted to take them out when they're tiny. And We took it out when it wasn't huge. I mean, it was taken out when it wasn't huge, but the outcome wasn't as good as if we'd done it earlier. But one neuro-oncologist said this medication, one said that medication, another said, oh, you use it, everybody loses their hearing when these come out. It's really hard when the professionals aren't on the same page. So if you can have a team meeting, if you can come to some conclusions that are unified for the patients that are making these tough decisions, the parents are, this particular mom's an occupational therapist. She picked up all these early signs on this young man, and she knew something was wrong. It was interesting. One neurologist told her to get MRI, one told her not to. They kind of went more conservative. But I think that they're all difficult decisions, and coming to an agreement if you can is helpful.
More that kind of basic sciencey question for Dr. Wellen and Dr. Wick. Dr. Wick, you showed a paper where you looked at like single cell.
There we go.
Where you looked at the single cell profiling of the tumors, and you found the macrophages that was like acid. Is it different if it's a sporadic vestibular schwannoma versus if it's associated with NF2? Like, are they, besides the NF2 gene mutation, are these tumors different in terms of their microenvironment and their genomics and how they function?
I think I missed the first part of that question, but I heard the last part. So if I incompletely answer, come back and ask again. But sure. I do think that the tumor microenvironment is an important consideration that we have not adequately addressed. And although we find some tumor markers that are elevated that associate with tumor size or lack of hearing, we also, I think, need to confirm these studies in a prospective fashion. And I think it's important to do it. We have a limited number of NF2 patients where we've looked at tumor macrophages, but I do think they're really important. And in some tumors, they make up to 50% of the cells in the tumor. So targeting tumor macrophages is probably what some of these treatments have done in the past, like everolimus or tacrolimus, or drugs that might be causing immunosuppression are probably treating the microenvironment more than they're treating the actual Schwann cell tumor. Cameron, did you have a comment? I'm not sure who that was directed to, but.
Yeah, the paper that I referenced were 15 spontaneous tumors. So I think, more investigation needs to be made, and the Schwann cell, abnormal Schwann cells in the NF2 population probably are working a little bit differently than the spontaneous tumors. So I think we have a lot to learn as a field on that. To Dr. Welling's point, we've all had patients that will have like a sudden sensory neural hearing loss, and lo and behold, give them some steroids and they get some hearing back. Of course, not all the time, and sometimes it's temporary, but you have to wonder, is that causing the inflammatory effect or impacting these myeloid cells that are responding to some type of nerve injury state?
Just one other interesting thought, talking about the vestibular rehabilitation and so forth. We have a couple of patients where we've done pre-bevacizumab treatment with rotary. We've looked at them in the rotary chair and looked for their VOR compensation and so forth. And in two patients with bevacizumab treatment, they've actually improved in terms of their accuracy and precision in the rotary chair on bevacizumab, which again is a surprise to me. I wouldn't have predicted that, but the same thing we see in hearing. Some patients, get an improvement in their hearing. I think there is an inflammatory component of that. We have human temporal bones of NF2 patients where the scala media is just completely packed with this eosinophilic protein. We don't really know what it is, but it makes me think that there's an inflammatory process that, in fact, if we treat with something like a VEGF inhibitor or a steroid that is anti-inflammatory, that maybe we reverse some of the process that's going on within the cochlea and the vestibule that actually allows them to have some improvement, even if it's temporary or rather modest in its effect.
Yeah, I just had a quick comment for Lexi as well. I'm glad to hear that Dr. Shi had felt the same way that I did with regard to the absolute benefits of our vestibular therapists. Lexi, there's been more than one occasion that you've made me look really, really good as a radiation oncologist with treatment of these patients. So I do appreciate you and give you a tip of the cap. In a perfect world, as a vestibular therapist, how would you like to see these patients manage to come in with, a modest amount of vestibular dysfunction prior to therapy? Like what would be an algorithm that we as the treating doctors should consider following in order to optimize patients' outcome after either surgery or radiosurgery?
And thank you for asking that question. I really think that having that initial vestibular rehab visit to establish a baseline of what their what their balance function is and like a functional assessment of their VOR can be really helpful for you so that we can see, after their treatment, if they are having a decline in their in the function of their vestibular ocular reflex or their balance, and that can give us information about why they're experiencing dizziness at that point. If everything is stable with that function, can also kind of help identify if there are other things.
See if Lexi's able to rejoin.
Persistent symptoms. So I think that just one initial visit before treatment is effective, and then at least once after too. So I think that would go a long way for helping patients who do present with the vestibular dysfunction.
You broke up a little bit in the middle of that discussion, Lexi. To recap, though, so one visit prior to treatment, but how far in advance of the proposed therapy in order for them to optimize function of their contralateral nerve, which, as I understand, is kind of what the whole purpose of those, at least from your talk, the whole purpose of those therapies are. So, like, how far in advance should they be doing these? And I would imagine the timing is probably different between surgery and radiosurgery, especially for what we've heard as far as the development of side effects being more acute or immediate, but with surgery as opposed to delayed with radiosurgery.
Right. So if they're undergoing a surgical resection, I would like to see them 6 weeks prior to their surgery date. That would give them at least 5 to 6 weeks of performing those exercises. And we know the literature on helping to achieve that central compensation for vestibular function can take up to 5 to 6 weeks of doing those exercises. So 6 weeks before surgery. As far as Gamma Knife goes, I'm not sure we have an ideal answer for that yet. And because of the potential delay in the onset of their symptoms after their treatment. Again, I would say as long as it's occurring at some point before. So I don't know if it's necessarily as imperative that it's that 6 week prior to their Gamma Knife, but if it's happening before, so that we can get a baseline of how they're functioning and instruct them on the exercises, as well as kind of help reiterate the fact that they may experience the onset of vestibular symptoms delayed after their treatment. So I think for a lot of patients, just having that additional meeting point where they get that information can be so helpful, because there's a lot that's really coming at them, when they're trying to decipher what they want to do, how they're going to make their decision. So, we have an hour, 45 minutes to an hour with patients. So we really have that time that we can spend to answer questions and, help educate them about the process.
Fantastic. Well, and hopefully our own investigator-initiated trial at MCW exploring the same will answer that question for us. So thank you for your deep involvement on that trial. I appreciate you.
Thank you.
Yes, I have a question for Lexi as well. There's some variation in our group on whether or not we get formal vestibular testing, so VNG, rotary chair, posturography, VHIT, etc. Do you find that extra information at the initial visit helpful, or are you getting some of it with posturography, sensory organizational testing. You're kind of getting some on your own, I would assume. So what is your preference?
Yeah, so we are getting some of that some of that information from the testing we do. As a practice, apart from the research study, our ENTs don't, as general practice, get those vestibular function testing like rotary chair and VNG before their treatment. For the study, we are having them undergo the caloric testing, just so we can maybe assess if there is any impact on their amount of vestibular function or loss of vestibular function that they have prior to the intervention, if that plays any role in their recovery of dizziness and balance after. But from my standpoint, I don't think that it's necessary to have the VNG rotary chair or more of those higher level tests done prior, because we can get good information about how they're functioning with the tests that we do.
There is one little caveat on that, I think, and that is that we found that patients that have rotary chair testing, that there are some patients that have quite a bit of dizziness going into their procedure, whether it's radiation or surgery or medical treatment. And we see that when patients have a tumor, they have a reduced amplitude of response to the vestibular ocular response.
Mm-hmm.
And there are some patients who have a degraded signal to the central nervous system that causes them to have a lack of precision or lack of accuracy. The amplitude's down in everybody. That doesn't seem to make a difference, but the precision does make a difference. If they have a lot of problems with their precision in terms of their VOR, treating the tumor actually improves their overall vestibular function. If they don't have a lot of loss of precision going in, then changing the signal coming in by taking out the tumor or radiating doesn't actually improve it. They may continue to have imbalance. So there is some thought. Rick Lewis, who's one of our neurologists here that Helen mentioned, is really clever on this. And it's interesting that he's able to predict whose balance is going to get better after treatment based on his pre-operative rotary chair VOR measurements.
Interesting. So do you routinely have everybody have the rotary chair before their?
No.
No.
Only those that have a lot of vestibular dysfunction or that we're trying to get into one of our studies. So
Gotcha.
We don't do it for everybody.
Yeah, the logistics of the testing is very challenging, especially as patients travel quite a distance to these treatment centers. So it's part of my question. Thanks, Lexi.
Yeah, you're welcome.
Great.
Yeah, thank you everyone for your participation and being part of this. This was a great, late morning session, and I think everybody together contributed pretty well to, I think, where the future of vestibular schwannoma is going. We heard a lot about what we did, but I really enjoyed how we're doing more, putting these implants in, we're trying to get function back, gene therapy, these treatments that are more or proton focused towards quality of life for patients and more innovation.
Yeah, 100%. I can't agree more. I just loved this whole morning. It was fantastic. Dr. Day and I commented during some of these talks. It's such a pleasure for us to put this together and to bring all of these experts to a State of Wisconsin symposium that we've had the pleasure doing together twice a year for the last 4 years, and has always been an amazing experience. And we appreciate seeing colleagues old and new as our expert panelists, and always a pleasure to have you join us virtually. We feel like we're able to capture more expertise when you're doing this from the comfort of your own office or home, or it looks like Lexi's actually at work as well, so that's great. But a sincere thank you to everyone. Please take time. You'll get an email with regard to feedback. We actually read all of those comments. We would love to hear future topics. We always invite our old panelists back as attendees, and we would love to hear what we can do to make this a better experience. We'll be reconvening this conference in the fall with our what's become our annual Brain Metastases Conference as a joint venture between UW-Madison, MCW, and ThedaCare. So thank you guys very much. This has been just a fantastic morning.
Mm-hmm.
Thank you.
Thank you all for organizing it. That was great.
You bet.
Thank you for the opportunity.
Thanks.